These are the most common SGLT2 inhibitors: the canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. Ertugliflozin is still not in the market. However, the top three are the most popular one, or the most known one. We can see that the empagliflozin and the dapagliflozin, they have the indication for heart failure patients. Other SGLT2 inhibitors include the sotagliflozin, which is the SGLT1 and 2 combination medication. We have in Japan, they have other type of SGLT2, epragliflozin, losagliflozin, and togagliflozin. These are some of the common side effects, and one of the most common one, the most serious one is the diabetic ketoacidosis. And this is why so many physicians or so many healthcare providers, they are reluctant to have type 1 diabetes be started on SGLT2 inhibitor. And we'll explain this later on the slides. We have the hyperkalemia, the UTI, and there are other side effects, but not as common. So just to go through some of the trials, the most well-known trials, as you can see, when it comes to the overall MACE, we have a couple of well-known trials, the EMPA, the CANVAS, and the CARDINANCE. For the second one, we can see that it's all in favor of the SGLT2 inhibitor. The second category we have by SCVD status. So patient with the SCVD risk, they in the EMPA and the CANVAS, they are in favor of the treatment, and patients without CARDINANCE is very clearly in favor of treatment. We can see by the overall CV, the cardiovascular death, as well as by the CV death by ACVD status. And most importantly, the hospitalization related to heart failure, we can see that all of the SGLT2 inhibitors show statistically significant in favor of the treatments. And so we are aware of how important the SGLT2 inhibitors when it comes to treating diabetes patient. The question is it for both type 1 or type 2? Most of the studies has been done on type 2, and we know as per the ADA guideline and what we know, the SGLT2 inhibitors are one of the medications or the initial medications you start for patients with a cardiovascular risk. So we know that we are not only caring about the treating the hyperglycemia, we also care about the other benefits, including the cardiovascular and renal benefit. So why explore non-insulin therapy? Some would say that some patients, they require a high dose of insulin, and so there is that weight gain. And also there are some patients who has variability in their blood sugars, making they are prone more to the hypoglycemia. In the US, only 17% of the youth achieved an A1C below 7.5. This is a very low percentage when it comes to our goal to control the patient diabetes. 21% of adults achieved an A1C less than 7%. In the UK, it's about 30% of adults with type 1 diabetes achieved an A1C below 7.5. So it's still a very low percentage, and this is what came to our mind, exploring other options to help patients achieve their goal faster and maintain their goal. Other benefits, we want to see if we can use the SGLT2 inhibitors in type 1, are they going to have the same cardiovascular and kidney protection as with type 2 patients? So do we go with the adjunctive therapy? The adjunctive therapy that we know in the studies, non-insulin off-label used, are metformin, GLP-1, and most commonly liraglutide, the pramlintide, and we have the SGLT2 inhibitors. So there are some options as an adjunctive therapy. Just want to say that all of these therapy cannot be used alone for type 1. It has to be in addition to insulin therapy. And so we want to know what's the ADA guidelines, if they have any recommendations when it comes to adjunctive therapy. And the only thing that comes with the ADA guideline is that the risks and benefits of adjunctive therapy consensus statements providing guidance on patient selections and precautions. So why do we want to go with the SGLT2 inhibitors? SGLT2 inhibitors, with recent studies, they have shown statistically significant reduction in A1C, less glycemic variability, decrease in total daily dose of insulin, blood pressure, and body weight. Additional benefit might be increased time in range without hypoglycemia. Patient-reported benefits, like they feel they don't use as many injections as they used before when it comes to corrections, and minimal risk of hypoglycemia, as I explained by the mechanism of action. So these are the most well-known trials that actually did use or study the use of SGLT2 inhibitors in type 1 diabetes. So we can see with the DPECT-1 trials, the two trials, they have shown a statistically significant reduction in the A1C, weight, and total daily dose. What's most important to us, we want to know the DKA incidence rate, and the DKA incidence rate with the 10 milligram, it's about 2.2 to 3.4%. 5 milligram is 2.6 to 4%, and placebo, it's about 0 to 1.9%. For the EASE trials, which was done using the empagliflozin, some of these doses are not used for type 2, including the empagliflozin 2.5 milligram, the 10 milligram and 25 milligram. The same result, it shows a statistically significant reduction in A1C, weight, and total daily dose, insulin dose. And the DKA incidence, it's might be slightly higher than with the dapagliflozin. 25 milligram, it's 3.3%. The 10 milligram, it's about 4.3%. And for placebo, it's 1.2%. For the sotagliflozin, which is only approved in Europe, it's not approved in the US, and I don't think we have it here in Saudi. It's the same consistent result. It resulted in a statistically significant reduction in A1C, weight, and total daily dose, and the DKA was about 3 to 4.2 for the 400 milligram and less with the 200 milligram. So we can see that we have now a data that support the use of SGLT2 inhibitors. However, is this going to be a generalization for anyone with type 1 diabetes? We'll find out. It's worth mentioning that the National Institution of Health and Care Excellence, after the DPECT-1 and DPECT-2 trial that was using the dapagliflozin for type 1 diabetes, they recommend the use of dapagliflozin for patients with type 1, not only because of the glycemic control and as well as the reduction in total body weight and total insulin dose. It's also, they found out that the incremental cost-effective ratio of 13,775 pounds per quality adjusted life year. So they found this option to be a highly cost-effective treatment, and that's why they are supporting as the reimbursement. They support the reimbursement of using the dapagliflozin. The Scottish Medicine Consortium, after that, they issue a statement recommending dapagliflozin for patients with inadequately controlled type 1 diabetes. But is it without a criteria? Of course not. So this guidance is by the National Institution of Health, and as we can see, it has three different colors: the green, the yellow, and the red. The green, it means you can use the dapagliflozin. The yellow, it's possible consideration of other side effects that might happen, so it has to be with caution, and do not consider prescribing. It's with the red color. So with the green, you can see that if the patient has a BMI overweight patient above or equal to 27, has established on stable optimized insulin therapy, the insulin dose, it's more than 0.5 units per kg of body weight per day. Presentation of ketones levels are less than 0.6, and willing and able to perform regular and frequent glucose and ketone monitoring. GFR is above 60 because all we know that SGLT2 inhibitors are all need to be renally adjusted, and age 18 to 74. So consideration, should I use SGLT2 inhibitor or not? The question should be a discussion between the healthcare provider and the patient. So you need to discuss with the patient that this is an off-label use medication. It may help you with your weight. It may help you with the A1C. It may help you reduce your insulin requirements per day. The other thing, the patients need to understand that they have to be on a regular follow-up or monitoring. So right now, it's easier with the type 1 to have a regular being available for. The reason why not a very high blood sugar, so the patients need to know the symptoms of DKA, the rapid weight loss, nausea, vomiting, stomach ache, and etc. And one more important note, if you already started the patient on SGLT2 inhibitors and you did not see any improvement in the A1C, which is defined by more than equal or more than 0.3%, then the risk outweighs the benefits and you need to discontinue the treatment. So the safety, it's very important to, as I said, to educate the patient about the DKA. It's very important to stick the appropriate criteria, the selection criteria, and it is important to know that the DKA is sometimes can occur at a blood sugars that not very high. Summary, I think while the insulin remains the mainstay of treatment of type 1, many patients are unable to meet their glycemic control. So looking for adjunctive therapy is an option to the healthcare provider to explore. Not all type 1 patients can benefit from SGLT2 inhibitor, and it's very important for us as a healthcare provider to assess the risk and benefit. We want to know are the long-term studies very important. We want to know if there is a sustainable reduction in the A1C, sustainable benefit to the patient. And other thing, if we can extrapolate the cardiovascular.
Me as a moderator will have a lot of things about type 1 diabetes and having oral therapy. I think now we'll move to the debate, and this is the first time to have a debate in IHOP, and everyone is excited about, so we will see that the debate. So we'll start with our first speaker in the debate, Dr. Tahani Mleibi. She obtained her bachelor degree in pharmaceutical science from King Saud University, and then she had her PharmD, then BGY1 and BGY2 for, in ambulatory care from University of Arizona in Tucson. Dr. Mleibi started her clinical experience at King Fahd Armed Force Hospital in Jeddah, then moved to King Khalid University in Abha to expand her expertise in academia and research in addition to her clinical services. Dr. Mleibi currently is Assistant Professor of Clinical Pharmacy in the College of Pharmacy at King Khalid University, and now Director of Pharmaceutical Services in King Khalid University Medical City. She is a board-certified specialist in pharmacotherapy and ambulatory care, and she is recognized as a consultant clinical pharmacist. So please welcome Dr. Tahani, and they will talk about, Dr. Tahani and Dr. Umayma, they will talk about should dual GIB-GLB replace the GLB therapy in weight management, and that's a trending topic in the market these days. So welcome, Dr. Tahani. And sorry for that. We'll have the second speaker in the debate will be the same thing in this debate, Dr. Umayma Arab. Dr. Umayma Arab is a pioneer in ambulatory care. Umayma, she earned her bachelor degree in pharmaceutical sciences. After graduation, she worked to the States, where she earned her Doctor of Pharmacy degree from Massachusetts University. Training in general clinical pharmacy residency, followed by ambulatory care. She special management and ambulatory care certification and medication therapy. Chair in the society. Now she is recently joined to the Saudi Food and Drug Authority as a scientific evaluation expert in the clinical trial department. Dr. Arab precepted and intern teach at Al Faisal University and participated in several events as a speaker and facilitator. So welcome for both speakers, Dr. Umayma and Dr. Tahani.
Well, thank you, Dr. Mukhtar, for this nice introduction. Thank you for the IHOP organizing committee and the scientific committee for this kind invitation to speak about the controversy, or let's say which class of GLP or the dual creatine would be the agent for weight loss. I actually will cover GLP, weight loss management, if that's the agent that should be actually used for those patients who wants to lose weight. And Dr. Tahani will it has been used and probably overused in the community for weight loss. We have so much shortage in medications because of the use and overuse. In cases, some type 2 medication, type 2 patients don't have the medication for their treatments. And I will share the evidence behind all what's happening about GLP and weight loss in this era. We have nothing to disclose. So I have quite plenty of studies. I'm going to share a few that are really important. The first one is a systemic review and network meta-analysis of all medications for weight loss. It is compared to each other, and in some instance with lifestyle modification. This is a trial that has included about 143 clinical trials. It 12 liraglutide, semaglutide, and exenatide were in this study. So in the results, we have seen that with about 6% of weight loss in the analysis of 24 trials, and that was about, for about 1,100 patients in these trials. Now, the second result was weight loss of more than 5 odds ratio that was significantly statistical in 15 trials. Now, to discontinuation of the agents that were used. Now, with the second has really good weight loss with exercise and just exercise alone or liraglutide. Published in New England Journal of Medicine in 2021, diabetes, weight loss was the main outcomes, and there was 4 arms. The first one, liraglutide alone, liraglutide with exercise, and the third one, exercise alone, and the last one is just placebo. So the outcomes here was weight loss for about 3.4 with the liraglutide with exercise, and the p-value was significant. Now, moving to the other arm that was liraglutide alone, we have seen less than 1 kilogram of weight loss. So here we can say that liraglutide with exercise is necessary, as you can see it in the red line and the red block. Another study actually we have here for liraglutide that was done again and published in the New England Journal of Medicine that showed that liraglutide 3 milligrams in addition to diet and exercise may reduce weight in adults with obesity and without diabetes. So in this trial, liraglutide has shown community. This so 100 patients. The sample size was female with obesity and no diabetes. Semaglutide versus placebo over 68 weeks. BMI more than 30 kilogram per meter square, and the goal was that semaglutide achievement that is up to 15%, 14.9%. So this is really I'm going to conclude with the last trial here for semaglutide, and this is for the once-weekly semaglutide versus liraglutide in adults who were overweight without diabetes and receiving consultation for diet and physical activity. This trial was last trial published in JAMA 2022, randomized, non-blinded. Patients were randomized to 4 arms, either liraglutide or semaglutide, placebo daily and placebo weekly. But those patients who were on the active medication were not blinded for the medication. Those patients had the BMI of 30 or 27 BMI plus a chronic condition. And the results of this trial, you can see here that there was a significant difference after week 28 to the end of the trial, and the semaglutide had weight loss more than liraglutide in this trial. And the weight loss was 15.8 compared to 6.4 weight loss in the semaglutide versus liraglutide. So here the p-value actually was significant, but as you can see it as well, it's in the graph here. And with that, I end the evidence behind both agents, the semaglutide and the liraglutide, and I will leave the podium for Dr. Tahani to share her evidence of the new agents and the weight management. Thank you.
السلام عليكم سعد مساءكم جميعا. Thank you, Dr. Umayma. We've known GLP-1 receptor agonists for a while now, since 2005, and it's made a lot of impact on our approach on how to manage type 2 diabetes and how to manage obesity. So the novel glucose-dependent insulinotropic polypeptide, in addition to glucagon-like peptide receptor agonist, it's been evolved lately, and the only medications in this class is tirzepatide, and it's the only one that work by activating glucose-dependent insulinotropic polypeptide in addition to its effect on GLP-1 receptors. It's a once-weekly medications that administered subcutaneously, and it's received the US FDA approval to be used in type 2 diabetes in May 2022. And just a couple months ago, it's received the approval to be used in weight management in October 2022. However, in Saudi Arabia, the approval application is still under the process in Saudi FDA. And I'll discuss in this topic two trials. The first one is SURMOUNT phase 3 obesity trial. It evaluates the efficacy and safety of tirzepatide in comparison to placebo for the weight management. The data of these trials has been published in New England Journal of Medicine in July 2022. It's a phase 3 multi-center, double-blind, randomized placebo-controlled trials, and it's conducted in 119 sites in 9 countries. A total of 2,539 individuals without diabetes, but they have to have obesity with a body mass index of 30 or more, or overweight with a body mass index of 27 or more, at least one weight-related complication. Patients were, all participants went through screening, then they randomized to receive either tirzepatide either tirzepatide 5 milligram or 10 milligram or 15 milligram or the placebo. The dose of tirzepatide initiated at 2.5, then the dose is increased by 2.5 every 4 weeks until they reach the randomly assigned dose. The follow-up or the total duration of treatment was 72 weeks. However, if the patient have pre-diabetes at baseline, they will follow up with them for additional 2 years. It looks at the efficacy and safety of tirzepatide in comparison with placebo, and their primary endpoints include percentage change in body weight from baseline to week 72, and also they look at the proportion of patients who meet their weight reduction target of 5% as a primary endpoint. For the secondary endpoint, they look for the proportion of patients who reach weight reductions target of 10% and 15% and 25% and 20%. And also they look at the changes in weight from baseline to week 20, and also any changes in waist circumferences. So There's two graphs in front of you. The one on the left look at the treatment effect of tirzepatide in respect to placebo for all participants who undergone randomizations, and regardless if they have discontinuations of treatment. For the one on the right, it includes the treatment effect of all participants who undergone randomizations. However, they have to receive, or if the treatment was administered as intended. So we see that there is a 15% weight reduction with tirzepatide 5 milligram, and 19.5 weight reductions in tirzepatide 10 milligram, and 20.9% weight reduction in tirzepatide 15 milligram compared to placebo 3.1% weight reduction. The proportion of patients who meet the target of at least 5% weight reductions was 90 with tirzepatide 50 milligram, which means for each 10% receive tirzepatide 50 milligram, at least 9 of them will get the benefit, or 9 of them will get at least meet their target of 5% reduction. Compared to a placebo. In terms of waist circumferences, the benefit of tirzepatide in waist circumferences already seen compared to placebo. However, the 10 milligram and 15 milligram was similar, and not a lot of difference between the two doses, 10 milligram and 15 milligram. Also, tirzepatide shows benefits in all secondary endpoints, including physical function scores, lipid levels, and diastolic blood pressures, and cholesterol. The most frequently adverse event that lead to discontinuations was GI side effect, including nausea, diarrhea, and vomiting. However, interesting thing that we see COVID-19 within the adverse effect, but keep in mind that this studies was conducted between the period from December 2019 to April 2022, where COVID-19 was an epidemic at that time. The second trials is SURPASS-2 trials. It's also a phase 3 trials. However, it looks at, as a primary endpoint, it looks at the efficacy and safety of tirzepatide in the management of type 2 diabetes. However, they use weight reductions, or they look at the weight reductions as a secondary endpoint. And this studies was published in New England Journal of Medicine in June 2021. However, the SURPASS trials compare tirzepatide to semaglutide, another, or to a GLP-1 receptor agonist. The semaglutide, all participants will go through screening, then they randomize to receive either tirzepatide 5 milligram or 10 milligram or 50 milligram, or semaglutide 1 milligram subcutaneously once weekly. Then they will proceed with a 4-week period of safety follow-up. A total of 1,879 individuals with type 2 diabetes who are inadequately controlled on 1,500 milligram per day metformin will be included in the study. And in addition, if they have also a body mass index of 25 kilogram. The median durations of follow-up was 14 weeks. And if we look at the chart on the left, the estimated treatment difference was 5.5 kilogram with the dose tirzepatide 15 milligram compared to semaglutide. And the treatment difference was 3.6 with the dose 10 milligram compared to semaglutide. And it's 1.8 1.9 kilogram with tirzepatide, the 5 milligram. And also we see reductions on the body mass index compared to baselines, and also the benefit in waist circumferences, but still we cannot see, still the waist circumferences differences between the two doses, 10 milligram and 15 milligrams, are similar. In terms of adverse events are similar between all arms, and the most frequently adverse event is GI side effect. So the key takeaways is all 3 doses of tirzepatide shows that it's superior to placebo in terms of weight reductions, and participant had a weight reductions of 19.5 and 20.9 with the dose of tirzepatide 10 milligram and 15 milligram. And when it's compared to semaglutide, the 15 milligram dose was brought a different treatment difference of 5.5 kilogram. The safety and tolerability profile is similar to those published published in SURPASS trials, and also similar to GLP-1 receptor agonists, where mainly or the most common one are GI side effects. Thank you.
Thank you, Dr. Tahani and Dr. Umayma Arab, for this nice debate. And I would like to invite all the speakers to the podium for the panel discussion. And I think before we start the panel discussion, so we'll have the first question for Dr. Umayma and Dr. Tahani is not a question, actually is a vote. So we want to vote who with GLB, who is with GLB, GIB. So who says GLB, 1? I need to see hands. This is the beauty of debates. No one? Oh my God. At least one. No one with GLB. Dr. Umayma, you don't convince them. So you need to convince them well. Yes?
Weight reduction of about 15%, which reflects almost to the same number, which is about 14 to 15 kilograms. And that weight loss was actually was seen after 4 weeks and then after 16 weeks. So we have really good results with the semaglutide here.
So what about GLB, GIB? Who say yes? I need to see hands. Nobody with anyone? Oh my God. We have the right side with GLB, GIB. So we like both? No? No one with GLB? Again, GLB? So all of them about GLB, GIB, so all the audience. So what's your comment, Dr. Tahani?
Well, as I said, we've known GLP-1 for a long time, and we've been using it and changed a lot of guidelines in terms of diabetes and weight management. And then the new concept or novel class came recently, and we expect it to come to the market, to the Saudi market soon, inshallah. It to provide a synergistic effect in terms of targeting 2 different mechanisms, providing more reductions in A1C and also more reductions in weight, in the benefit of the patient without providing any more adverse effects.
Okay, thank you. So my question to Dr. Fahad, having a SGLT2 to a type 1 diabetes is a new thing nowadays and will change a lot of practice. So having a DKA risk still is high, a little bit high with 4% with such cases, and you presented in the guidelines that certain criteria in the NICE guidelines, there is a certain criteria to prescribe SGLT2. So, and you mentioned that there is a monitoring, you need to monitor your patient for ketosis. So in terms of practicality, how frequent should the patient monitor himself, and in terms of even in the clinic, so how frequent we need to monitor?
So I think what's the recommended is at least to have 1 to 2 months follow-up with the physician. In terms of the ketone levels, it's every 3 months. The recommendation is every 3 months to have the ketone levels when the patient is at SGLT2. The other recommendations, you have to evaluate the patient every time you see the patient for any risk of DKA. So if the patient at the initial visit is qualified for the SGLT2 inhibitors, and then something happened, they are at higher risk either by recent admission or by any other circumstances, you have to re-evaluate the patients. In terms of monitoring, I think I have to be honest with everyone. It's especially with the challenges that we are having currently in access to care and all of that, it's not actually practical to have the patient, come every 1 to 2 months to follow up. And most of the patients, they will say, you know what, most of our patients, they don't want a frequent follow-up. So they would say, no, I want to see you twice a year or something. And so I think at this stage, it might be difficult unless you have a control over the patients and they are in an agreement with regards to frequent follow-up.
So thank you. So I think we'll have 1 or 2 questions from the audience because we are running out of time. So questions. So can I have the mic there? Okay, go ahead.
Assalamu alaikum. Nader Shraim. First, I would like to say thank you, Dr. Fahad, Dr. Umayma, and Dr. Tahani about this informative presentation. I have 2 questions and 1 comment, if you allow me, just quickly. Regarding Dr. Fahad, we know that there is evidence that SGLT2, GLP-1 can be used for patients with type 1. But practically, how can we convince, for example, physician or the clinical pharmacist or any healthcare providers? What's the cutoff point? For example, if I mention to the patient that I will add a medication rather than increase the doses of insulin. So that's when sometimes it's difficult. It's need a discussion with the patient. The second question, Dr. Umayma and Dr. Tahani, about the price. Global study they conducted globally, they found worldwide that around 80% of the healthcare providers, they define the obesity as chronic disease. Unfortunately, in Saudi Arabia, when they conduct this study as questionnaire, they found just only around 60%. They define it as obesity. So the cost, still the big question for all health institution, how we can convince the higher administration, because our practice with the regularitide is take a lot of the budget for the treatment. In the Saudi Arabia, around 33% are obese. So it means that millions of people they indicated for this medication, which may take the cost. Thank you so much.
Thank you. So the first question for you, Dr. Fahad.
So as I said, when I went through the NICE recommendations, their cutoff is more with the A1C. So if there is no any improvement in the A1C of 0.3% or more, then the risk outweigh the benefits for the patients and you need to stop the treatment. Regardless if the total daily dose of insulin is now less with the presence of the SGLT2 inhibitor.
Second question for Dr. Umayma and Dr. Tahani.
In terms of the price, tirzepatide for sure will be expensive. GLP-1 are expensive as well. And when you look at the benefits, you add to the formulary one medication that can target two conditions. And the amount of weight reductions and the amount of A1C reduction that we see with tirzepatide is exceeding any other GLP-1, not any other, sorry, I take this back, exceeding at least semaglutide, because it's the only GLP-1 medications that have head-to-head trials with tirzepatide. So the benefit is still exceeding the cost, and the cost of GLP-1 is already high.
Okay, I think we are running out of time. So the last question for you, Dr. Umayma and Dr. Tahani, specifically for Dr. Tahani, is GLP-GIB now compared to semaglutide as a trial in the Surmount, I think in the Surpass-2 trial, they mentioned that they compare semaglutide to tirzepatide. So is it fair to compare semaglutide to 1 milligram, is not the 2.4 milligram, with the GLP-GIB, which is a weight reduction dose?
Okay. The Surmount trials compare tirzepatide to placebo, and it was an obesity trials. It's very important to know that Surpass trials is diabetes trial, so their main and primary endpoint to look at A1C reduction and look for diabetes management. And they had a secondary endpoint as looking for weight reduction. So their main endpoint was to look for its effect on diabetes management, and they're using a dose that's usually used for patients with type 2 diabetes.
Okay. I think with that we'll conclude our session. So hope to see you in the next session. We have a lot of debates today, and thanks for all the speakers. We know that we have a good debate today, tirzepatide, semaglutide. I think tirzepatide have a future in obesity management. We are waiting still for the trial for cardiovascular and renal protection and all these things. So SGLT have new things in the market now, and new things, and new bright futures in type 1 diabetes. And I think we have fruitful discussion today. Thank you all for your speech. Thank you.
Thanks to our speakers and moderators for their great presentations. And now I would like to invite Dr. Mohammed Al-Shennawi for the recognition. دكتور مختار العمر. دكتور فهد الدوسري. دكتور تهاني البليبي. دكتور أميمة عرب. And me, دكتور البندري الغامدي. Dear audience, we would like to move to the next session, which is about infectious diseases. This session will be moderated by Dr. Sarah Mhaysen. Dr. Sarah is American and Saudi board certified in infectious disease pharmacotherapy, antimicrobial stewardship pharmacist from American Society of Infectious Disease Pharmacists. Dr. Sarah completed her PGY1 pharmacy practice residency at King Fahd Medical City and PGY2 infectious disease pharmacy residency at Prince Sultan Military Medical City. She earned her PharmD degree from Princess Noura bint Abdul Rahman University with first-class honors. Currently, she is an active board member in Infectious Disease Pharmacy Specialty Network in Saudi Society of Clinical Pharmacy, as well as member in Antimicrobial Stewardship Committee at King Fahd Medical City. Please help me to welcome joining Dr. Ma.
Assalamu alaikum. Good morning, everyone. First of all, I would like to thank the organizing committee for invitations. We have in ID session two hot topics. First topic with speakers Dr. Shrouk Al-Lawes. Dr. Shrouk is assistant professor at Department of Pharmacy Practice at King Saud bin Abdulaziz University for Health Science and Infectious Disease Clinical Pharmacist at King Abdulaziz Medical City in Riyadh. Dr. Shrouk completed her pharmacy practice residency at Massachusetts General Hospital, her infectious disease residency in Columbia. Dr. Shrouk, her research is oriented toward the antimicrobial research, antimicrobial stewardship, multi-drug resistant organism, pharmacoepidemiology, and medical education. Dr. Shrouk, she will talk about a very interesting topic about calcium sulfate beds mixed with antibiotic in orthopedic surgery, what pharmacists need to know. Dr. Shrouk, she will join us through the Zoom. Please welcome Dr. Shrouk. to the second presentations until to correct the connections. Second speaker, we have scientific debatable topics about the use of linezolid for Staphylococcus bacteremia infections is optional. Our speaker is Dr. Khalid Al-Jali. Khalid is Associate Professor in Faculty of Pharmacy and Head of Health Interprofessional Research branch in the University Vice Presidency for Development at King Abdulaziz University. He is Consultant Infectious Disease Pharmacist and Infectious Disease Pharmacy Program Director at King Abdulaziz University Hospital. Dr. Al-Jali also Honorary Research Fellow in College of Pharmacy at University of Arizona. He completed his BGY2 Infectious Disease Pharmacy Residency at BIDMC, Harvard's Medical School in Boston. Then he completed both Antibiotic Stewardship Pharmacy Fellowship and Master of Science in Clinical Translation and Research at University of Arizona. He is active member of the Global Respiratory Infection Partnership and fellow of the American College of Clinical Pharmacy. The second speaker, Dr. Ahmed Taqi. Dr. Ahmed, Assistant Professor at Faculty of Pharmacy at Kuwait University and ID Pharmacist at MOH in Kuwait. He is board certified pharmacotherapy specialist. American board. He holds a pharmacy degree from Liverpool University. He completed his BGY1 and BGY2 infectious disease specialty in Steward Medical Center, USA 2020. He postdoctoral research fellowship at Brigham and Women Hospital in US 2021. Please welcome for both speakers, Dr. Khalid Jali and Dr. Ahmed Taqi. They will present very hot topics about linezolid and Staphylococcus bacteremia. Is it option or not?
Assalamu alaikum. Thank you for the introduction. And first, I would love to thank the MOH for inviting me. I'm really pleased to be here with my colleagues and friends in Saudi. So, start our discussion today, a debate about linezolid for staphylococcal bloodstream infection. Is it an option or not? I think. Okay. So, the objectives for today's talk, we'll first bacteremia, and then we'll discuss some clinical evidence about the efficacy and safety of linezolid for staphylococci bacteremia. So before we start our debate, it's good to give you some context. Start with linezolid. It's a oxazolidine broad-spectrum gram-positive bacteria. VRE. In the US and the FDA, it is licensed for the treatment of complicated and uncomplicated skin and skin structure infections, as well as pneumonia, and also for the treatment of vancomycin-resistant enterococci infections. However, it's not licensed for the treatment of for bacteremia, bloodstream infections, and that will be the topic for our discussion today. And why do we care about the staphylococci bloodstream infections? Staphylococci or Staph aureus is a common colonizer of the human skin and nasal area, and it can cause breakthrough infections resulting in some complicated and uncomplicated infections. Staphylococci aureus bacteremia is, when untreated, can cause high mortality and morbidity burden. For uncomplicated cases of Staph aureus bacteremia, the treatment is usually a minimum of 2 weeks. And in cases of complicated and metastatic disease, the treatment actually can be extended to 4 to 6 weeks of antibiotics. Some predictor for good outcome is source control, duration of bacteremia, other comorbidities, as well as time to optimal antimicrobial therapy. So first, I'll start with being against the use of linezolid for bacteremia. And some of the points we'll discuss, and I'll explain each one in more details. The first argument would be that linezolid is a bacteriostatic agent. It has some adverse drug reactions that we want to avoid. comes with some drug-drug interactions, and it's not licensed for more than 28 days. And then finally, I will discuss some evidence against the use of linezolid for staph bacteremia. So why do we care about an agent to be bacteriostatic versus bactericidal? So bacteriostatics mean the agent will not kill the bacteria, but rather would prevent the growth of the bacteria. And this becomes significant, in my view, as an against linezolid, is there is a recent paper as the duration of staph bacteremia extends. And you can see from the graph here, as the duration of bacteremia increases beyond 3 days, the risk of mortality is significantly higher. And the argument would be, although it's not proven, the argument would be a bactericidal agent that kills the organism could potentially result in quicker time to clearance of the bacteria. And hence why we would use or prefer to use a bactericidal for staph bacteremia. The second point, or the second argument against linezolid, is that it comes with a thrombocytopenia. And here I list this table from a meta-analysis of randomized controlled trials that compared linezolid to vancomycin. And you can see clearly from the last line the total percentage of thrombocytopenia was more in linezolid compared to vancomycin, which vancomycin itself comes with a minimum risk of thrombocytopenia itself. So this staph bacteremia treatment is a minimum of 2 weeks, so the risk is higher. Also, it can result in treatment discontinuation. One paper actually documented 50% treatment discontinuation from using linezolid treatment. The good news, though, it's mostly reversible as we stop the treatment agents. The next point would be drug-drug interactions. Linezolid in itself is a weak monoamine oxidase antagonist, and as a class that comes with a lot of drug-drug interactions. Most serious one would be interacting with serotogenic agents and increase the risk of serotonin syndrome. And then I list some of the classes of medication, most commonly antidepressants, SSRIs, tricyclic antidepressant, and of course monoamine antagonists. And this actually becomes more and more relevant today as the use of these agents is increasing. The diagnosis of psychiatric illness is increasing, as well as the use of these agents for other indications as well. So one study reported the risk of SSRI or serotonin syndrome with linezolid and other serotonin agents to be as low as only 0.1%. But this actually can be devastating and life-threatening. Next, I will discuss two studies actually showed some negative outcomes when linezolid is used for bacteremia. The first paper here by Usery and colleagues is a single-center retrospective study that looked at linezolid versus daptomycin and vancomycin for MRSA bacteremia. Mostly were primary or catheter related. And their primary outcome was clinical cure, which didn't show any difference between the group, but they had one of their secondary outcome, which was all-cause mortality, and linezolid has a significantly high percentage of mortality, 40% compared to 19 with daptomycin and 9 with vancomycin. Actually, Wilcox and colleague, it's a multi-center that looked at linezolid for the treatment of skin and skin structure infections compared to vancomycin if it's MRSA or oxacillin if it's an MSSA. And then the primary outcome looked at microbiological outcome at test of cure. We didn't find any difference between the two groups. But actually, when you look at the secondary outcomes and the analysis, there is intention to treat mortality at day 84 of therapy, and there was an increased risk of mortality in the linezolid group. This actually led the FDA to issue a warning against the use of linezolid for treatment of catheter-related infections. And that's a very good reason why I would be against the use of linezolid for bacteremia. Now Dr. Khalid will try to tell you why he's with linezolid.
Assalamu alaikum. Good morning, everyone. I would like to thank the scientific and organizing committee for this wonderful conference. Thank you, Dr. Sarah, for the kind introduction, and Dr. Ahmed for discussing why you are. But let me now present to you why I think we should use linezolid. Okay. First of all, let's admit that linezolid have some advantages over vancomycin or the other parenteral therapy for MRSA. It's available orally. This is a big advantage. As Dr. Ahmed said, when we treat bacteremia, if it's uncomplicated, then we need at least 2 weeks. Many times it's complicated and we need 4 weeks or longer. So to keep patients on IV all these duration, it's not good for all patients. So it's an advantage to have something that we can use orally. Now, we need IV. I will not go over this debate, but anyway, linezolid is equivalent orally with the IV. The bioavailability is almost 100%. So don't worry about giving something oral for now. And when you talk about IV therapy, they are not the best, right? IV therapy, lot of issues, less convenient, and the catheter-related complication. So it's not that linezolid is just less safe. We have issues with giving IV therapy for MRSA bacteremia. In addition, as you know, vancomycin, the first-line agent for MRSA bacteremia, it needs therapeutic drug monitoring. It becomes even more challenging as outpatients. One of the advantages of linezolid is that generally it doesn't need therapeutic drug monitoring compared to vancomycin. So all of these are advantages. And Dr. Ahmed was biased. He presented only the data that showed linezolid is bad, but we have data showing that linezolid is fine, is as good as the standard therapy. So let's see. First of all, we have this first article published in 2005, and this is actually a pooled analysis of 5 RCTs. So it's close to a meta-analysis. And I only looked specifically because, when linezolid was studied, it was studied in pneumonia, skin infections, but we have a subset of patients in those RCTs who had also secondary bacteremia. So if we took this subset with MRSA bacteremia, we have around 36 patients in linezolid group and 37 patients in vancomycin group. As I said, 5 studies, MRSA bacteremia in the RCTs. Pneumonia was the source, by the way, in 40% of cases. As you know, some data showed that linezolid may be better. It's debatable in case of pneumonia compared to vanco. If you look at the outcomes, no significant difference between the two groups in clinical cure. So 56% in linezolid group, 46% in vancomycin group. And overall survival, almost the same, about 65%, no difference. So based on data from RCTs, we didn't find a difference here. Unfortunately, we don't have an RCT, simply linezolid versus vanco for MRSA bacteremia. But anyway, when you talk about bacteremia, most of the time, for any agents, we will not find RCTs. It's very rare to find an RCT with bacteremia, the sample size is one of the biggest issue. But there are some observational studies by now, so let's present those. So the first one is published in 2012 by Park et al. This is a single center prospective cohort study, and they compared linezolid and they combined it with carbapenem in half of patients, 38 patients versus glycopeptide in 52 patients. Now, it's important to note that all these patients had persistent MRSA bacteremia. Okay? So let's see if linezolid was good in those patients. They needed salvage therapy because of persistent bacteremia. Something to note about the differences between the two groups. If you look at the linezolid group, they had longer duration of persistent bacteremia. So 16 days versus 10 days. Also, they had higher rate of infection acquired in ICU. So 33% versus 15%. This is important because it could affect the outcomes, especially. And as expected, if you look at the early microbiological response, no significant difference statistically, but numerically lower microbiological response in linezolid group, and longer duration until culture conversion after 7 days. But again, if you look at the baseline, they already had longer persistent bacteremia. So this doesn't mean linezolid is worse. Plus, what's more important is what? The clinical outcomes, not the microbiological outcomes. Treatment success, no difference, about 70% in both groups. And 30-day mortality, 11% versus 25%. So numerically, it was in favor of linezolid group, but it was not statistically significant because the p-value is 0.08. But at least linezolid here didn't increase mortality. Was it the reason for lower mortality? It's difficult to say that in observational studies. Even after logistic regression and propensity score matching, the same outcome, no difference. The next study was published just 4 years ago by Jorgensen et al. This was a single center, retrospective propensity score match study. Now in this study, the first group was not only linezolid alone, it was oral outpatient antibiotic therapy, 70 patients. 50% of them received linezolid. So they are looking more at oral versus IV, more than linezolid specifically, compared to IV, either Vanco or Dapto mostly. Now, those patients needed to have clearance prior to hospital discharge. And about half of them have primary or catheter-related bacteremia, and 2/3 had complicated bloodstream infection. If you look at the outcome, 90-day clinical failure, no difference between the two groups, numerically in favor of linezolid, but didn't achieve statistical significance because the hazard ratio crossed 1. And if you look at the secondary outcomes, lower adjusted hazard ratio with linezolid, 0.6, in the 90-day hospital readmission. So again, at least linezolid was not worse. And the last study was published just last year by Yeager et al., another retrospective study. Now, this study did something different. They compared oral step down versus continuing IV therapy. The propensity score match patients were 54 in both groups. And they required, again, clearance of MRSA culture prior to hospital discharge. Unfortunately, the two groups were not balanced, which is expected in retrospective studies. So more patients in the IV group had complicated bacteremia, 70% versus 40%, and more metastatic foci, 45% versus 20%. and they received longer duration of therapy, 45 days versus 22 days. So in this study, without propensity score matching, you will not trust the result at all. But with propensity score matching, it reduces the impact of confounding factors. Now, if you look at 90-day infection-related readmission, no significant difference. In the matched patients, 17 versus 30. All-cause mortality 90 days was 4 versus 6. As you can see, the percentage is low. They were not at high risk of mortality because they were outpatients. They required clearance of bacteremia. No difference in length of stay. And no difference in side effects, by the way. Even though the median duration in linezolid was 22 days, there was no difference in the overall side effects. But if you look at the adverse events requiring rehospitalization, it was significantly lower in the linezolid group. 2% versus 12%, statistically significant. These are the studies, not the best studies, mostly observational or pooled analysis from RCTs. Frequently it showed linezolid might be better or at least not worse. Now for the rebuttal. I already presented the data why linezolid can be an option. We are not saying it's an option for all cases. I'm not saying replace vanco for all patients and use linezolid. No, but it can be an option. Unlike what is done now in many hospitals, they never give linezolid for MRSA bacteremia. But what about what Dr. Ahmed said? He presented valid points, some issues with linezolid. So now we're going to discuss those points. First of all, the side effects. A lot of people say, no linezolid for bacteremia. Why? Because of side effects. This is important to consider, important to counsel, important to monitor, but it's not a contraindication. You can still try linezolid in those patients. Not all patients develop those side effects. Plus, patients with uncomplicated bacteremia can be treated with just 2 weeks. Most of the side effects appear after 2 weeks, so you still can use it, or you can start with IV therapy and then switch to complete the remaining duration with linezolid. So it's not a contraindication, and you can monitor these side effects, especially the most important one, thrombocytopenia. You can monitor the platelet. It's not difficult. If the patient develops severe thrombocytopenia, then you can change, and it's reversible, as Dr. Ahmed mentioned. IV therapy is not without complications. We mentioned the catheter-related complication. It's less convenient. Some hospitals don't have OPAT, so they keep patient inside the hospital for a long time. And with regard to the drug-drug interaction, this is a whole debate. But as Dr. Ahmed said, linezolid is a weak MAO inhibitor, unlike the old antidepressants. So the interaction is debatable. It's not an absolute contraindication. You will see many hospitals, and some of them publish their data, showing that maybe it can be used in some cases, especially if someone is not on high doses, not on strong serotonergic agent or multiple agents. It's not an absolute contraindication. Plus, especially in our community in Saudi Arabia, the majority of patients are not on serotonergic agent. So this drug interaction doesn't affect the majority of patients. The other point, a lot of people mention it. Honestly, at pharmacy school, most of us teach it, static, and it seems like it's less effective, but there is no proof at all. Static matters clinically, no proof. We have this fear, but many consider it a myth. So until now, we don't have evidence. Static is bad. We have more important issues: the dose, the pharmacokinetic, the drug itself. These are much more important than static cider. And by the way, a published systematic review, very interesting, supervised by Brad Spielberg. Many of you know them from Twitter. He's a very famous ID physician. And what they did is that they compared all the randomized controlled trials that compared bacteriostatic versus bactericidal. What do you expect? More death with static? No. They included how many studies? 56 studies, 56 RCTs. What are the result? No difference in 49 of them. Almost all except 7. No difference at all. What about the remaining 7? In 6 out of 7, the static was more effective. In 6 out of 7, the static was more effective. So it's not the most important thing, static. We have other more important stuff. The dose, the pharmacokinetic. Okay, we have just one RCT that showed Sidal was more effective. Why is that? In that study, they compared tigecycline, this was the static agent, versus imipenem for VAP, and they found higher mortality with tigecycline. And this is not likely due to being static, but it's most likely due to maybe the dose. That's why this dose is no longer recommended generally for pneumonia. The tissue penetration is not good with tigecycline. Now the recommended dose is higher than the approved dose, double the dose. And when they published a small RCT about this, they didn't find a difference. So no single study using a good dose ever showed static to be less effective.
Dr. Khalid.
Since Dr. Ahmed actually agrees with me, now we are in the rebuttal, he's gonna continue and finish the rebuttal why we think linezolid should be at least an option in MRSA bacteremia.
Thank you, Dr. Khalid. So Dr. Khalid did a great job. He convinced me to change my mind, and I will reconsider the evidence I posted earlier. So the first trial, the usury trial that we showed, had an all-cause mortality higher in the linezolid group. It actually had a lot of limitations. It's first single-center retrospective. It's unbalanced. Only 15 patients in linezolid compared to 53 and 54 on daptomycin and vancomycin respectively. And it has some other limitations as well, that linezolid was only started by ID physicians, which give you a suggestion it could be more sicker patients. And with all the evidence Dr. Khalid actually presented before I come up, it's actually makes me more comfortable to kind of overlook this study due to its limitations. The second study, which is actually a big one, that actually showed the increased intention to treat mortality in the intention to treat group on day 84 of linezolid, actually had also its own limitations. When they looked at these intention to treat group, they found that the increased mortality was mainly driven by those with culture negative, they didn't have any positive culture, or they had a mixed gram-positive and gram-negative culture. And when they looked at the only gram-positive, which is the modified intention to treat group, they didn't find any difference between the two groups. So a way to look at it, if you want to be extremely conservative, you can suggest we will avoid using linezolid empirically for patients, but if you have a culture positive and you're positive it's a gram-positive infection, linezolid, as shown by Dr. Khalid, can be a good option for certain infections. So just to summarize, unlike what we thought before, there is good volume of evidence to suggest linezolid can be a reasonable option for the treatment of MRSA and staph aureus bacteremia in general, particularly in uncomplicated cases or as a step-down oral therapy. Although more high-quality RCTs would be required to confirm the exact efficacy of linezolid for the treatment of staph bacteremia and the ideal target population in which linezolid can be used for. With this, I think we conclude, and we can have more questions or comments in the panel discussion. Thank you.
Thank you, Dr. Khalid and Dr. Ahmed, for very informative and excellent presentations. So now we move to the second speaker, Dr. Shourouk Gilawais. Dr. Shourouk, she is a clinical pharmacist at King Abdulaziz University. Dr. Shuruk, she is a clinical pharmacist at King Abdulaziz University in Riyadh. Dr. Shuruk completed her residency program at Massachusetts Hospital in Colombia. Dr. Shuruk, her research is oriented toward antimicrobial stewardship, antimicrobial multi-drug resistant organisms, pharmacoepidemiology, and medical science. Dr. Shuruk, she will present a very interesting topic about calcium sulfate-based mixed antibiotics in orthopedic surgery, what a pharmacist need to know. Dr. Shuruk, she will join us through virtual. Please welcome Dr. Shuruk. Because of the clinical issue, so we will move to the questions because Dr. Shuruk, she have clinical issue. So now we have questions for Dr. Ahmed Taqi and Dr. Khalid. Please join us on the stage. Any questions for Dr. Ahmed and Dr. Khalid? Any questions? Can you please bring the mic there?
السلام عليكم.
بس ما نسمع الصوت.
Thank you. Hello. Assalamu alaikum. Thank you, Dr. Khalid and Dr. Ahmed, for the nice presentations on informatics. I have a couple of questions. The first one, what about in regard of antimicrobial stewardship? If we think of from ASP point of view, just keeping the linezolid for the more cases that have a resistance and just treat the patient with the first line options as a standard therapy. The second question in regard of the cost, which one is more cost effectiveness, the vancomycin or linezolid? The third question, if there's any real cases in your institution, you treated patients with linezolid, either IV or oral. Thank you so much.
Okay, actually all questions are excellent. Thank you very much. Okay, so sorry, what was the first question?
First question is about from
okay,
ISP.
yeah, the stewardship. Okay, yeah, very good point. And always in practice, as you know, we consider several factors, not just one factor. So if we just talk about stewardship and we want to keep linezolid for VRE or specific cases, but let's look at the other advantages that we presented. You could argue that even with stewardship, considering stewardship, some might think, well, still I'm going to use linezolid. Why? A lot of hospitals, they keep the patient in the hospital to continue the whole course. As you know, if you keep the patient in the hospital and on IV, on catheter, they will be at risk of resistance, including multi-drug resistant bacteria. So it's a balance, it's a risk-benefit. Keeping a patient in the hospital, using catheter have its risk. And yes, I agree, some have issues with linezolid that you want to save it for selected cases. I think it's risk-benefit. I don't think we are saying use linezolid for all patients, but at least we want to change the previous idea that I will never use linezolid. It's static, or there is an FDA warning. This is our main goal from this debate. Does that answer your first question? So it's important, but it's risk-benefit, right? Okay. And the second question about
The cost.
the cost, Dr. Ahmed.
Yeah, also a second good question. So if you look at the cost of the drug itself, yes, linezolid would be relatively more expensive than vancomycin. But if you look at it collectively at the cost that vancomycin can cost, you look at the staffing, you need drug monitoring, you need levels, you need pharmacists dedicated to do the calculation of vancomycin. And then you also, if you calculate the length of hospital stay, linezolid would facilitate discharge from hospital quickly. So if you add all these up, I think the cost effectiveness of linezolid you can argue it will be more cost effective than vancomycin. And then the third question, I don't remember. What was the third question again?
It's only 2 questions. 2 questions only.
2 questions. Thank you.
Could you please bring the mic to Dr. Nada? No, there is questions there. So we have just 2 more questions, Dr. Nada, and the last question from there.
Assalamu alaikum. Thank you so much for this great presentations in this mind-changing discussion. So from the discussion today, I can see that linezolid will become the new vancomycin in the new era or future. So what do you think are the problems that may come with using or substituting vancomycin with linezolid in the future?
So these questions, who will answer? So Khaled?
I mean, we can both answer. I don't think linezolid would take vancomycin, take the place of vancomycin. Vancomycin is still our go-to and first-line treatment for most staff, and specifically MRSA infections. But what we try to say here is we shouldn't overlook linezolid when we have staph bacteremia specifically. It has its role. It showed to be effective and safe for the treatment of staph bacteremia. So I don't think we want for linezolid to overtake vancomycin as the first line for MRSA infections.
So last questions, then we can conclude our sessions. This question for Dr. Khaled and Dr. Ahmed about the drug-drug interaction. So you know when the pharmacy they're checking the linezolid with SRI, they will found in category X, so should be contraindicated. Is it absolute contraindicated? Because sometimes we need to use linezolid because the patient have allergic for vancomycin or whatever. So is it absolute contraindicated to use linezolid with the SRI agents?
Absolutely not. Actually, there is a good paper that came out about 2 years ago and looked at I think 1,800 patients who took linezolid with serotonergic agents, and they only reported 2 incidents of serotonin syndrome, which tells you the rate is very low. But there are certain agents, as citalopram, escitalopram, and methadone that comes with a higher risk of serotonin syndrome in themselves. So maybe patients with these agents you want to be extra careful with, but I wouldn't say it's an absolute contraindication.
Yes, I totally agree with Dr. Ahmed. Sometimes the manufacturer, they have to put in the prescribing information, it's contraindicated because it's a MAO inhibitor, simply, like the older antidepressants. But is linezolid itself contraindicated? Well, it's a weak MAO inhibitor. As Dr. Ahmed said, some hospitals publish their experience. They are using linezolid in a lot of patients who are on agents that increase serotonin, and the incidence of serotonin syndrome was too rare. So I would worry the most if someone is on, let's say, a strong serotonergic agent like SSRI, high dose, multiple serotonergic agents. I will worry the most in those patients. But you will find some agents, they increase some neurotransmitter, including serotonin, a little bit, and you will see a contraindication in the database. This is not actually an absolute contraindication. If you can avoid linseed use something, that's fine. But if you have to use it, it's not an absolute contraindication.
And just to add something, it's an additive risk. So if you have someone on more than 2 agents, maybe you want to be careful. But if only a single teratogenic agent, you can feel slightly more comfortable to use it.
Thank you, Dr. Khalid, Dr. Ahmed, for very informative talk. So we can conclude our ID sessions. Thank you for all attendance.
Thank you.
Thanks to our speakers and moderator for their great presentation. And now I would like to invite Dr. Abdulrahman Al-Suwaidi for the recognition. Dr. Sarah Al-Mhaysen. دكتور خالد الجعلي. دكتور أحمد تقي. Dear audience, we would like to proceed to our third session where we'll be highlighting the underrepresented topic, which is very important. We will be talking about neurology. And this session will be moderated by Dr. Abdullah Al-Hmaidan. Dr. Abdullah is the Director of Pharmacy Department and Consultant Clinical Pharmacist and former Chief Operation Officer at King Khalid Eye Specialist Hospital. He was the Executive Director of National Drug and Poison Information Center at Saudi Food and Drug Authority. In addition, he worked at King Faisal Specialist Hospital and Research Center as a clinical pharmacist and the Acting Director of Pharmacy Department. He completed his PharmD degree from Campbell University and his master degree from Tulane University. And then he took his postdoctoral fellowship degree in pharmacokinetics and critical care neurology from the University of Louisiana. Dr. Abdullah, the stage is yours.
Assalamu alaikum jami'an. Good morning, everybody. I would like to thank the organization committee for giving me the opportunity and participate in this meeting. And I wish the best luck for all the speakers, and I hope you enjoyed the 3 days. Our speaker for today in neurology section will be Dr. Yahya Asiri. Dr. Yahya Asiri is Associate Professor at the Department of Pharmacology and Toxicology, College of Pharmacy, King Khalid University in Abha. And he had his PharmD in Pharmacology University of British Columbia, Vancouver, and the BS or Bachelor degree from King Khalid University, College of Pharmacy. His topic for today will be under the name of Translational Research in Neurology, Hopes and Challenges. Please welcome Dr. Yahya.
Assalamu alaikum wa rahmatullahi wa barakatuh. Before I begin, I would like to thank the organizing committee for organizing such a wonderful event like this. And I'm grateful for the opportunity to talk to you today about an important topic. Yes, it's a bit far from your interest since most of the talks that I attended is mostly clinical, so bear with me, it's going to be a bit of jargon that you may not be familiar with, but inshallah we'll help you to understand it as much as we can as we go through the presentation. The topic is a bit broad, but inshallah we will have a specific topic in neurology that really reflects what is happening in developmental research and neurology or translational research. What I want from all of you by the end of this talk is to really understand the concept of translational research in general, review the advances in neurology. We're going to give one example that hopefully it will be applicable to all neurological disorders, which is the field of pain research, and also understand the challenges facing researchers in neurology. Some of you may ask, why are we even bother about translational research? It's something that we're not interested in. No, you are a pharmacist, you are a drug expert, you should be aware of the drug from the initial development up to its clinical usage. No one in the other fields would be aware of a lot of things that are happening during the development stage up to getting it approved. The translation research is not a luxury. It's a must that we should all know that there is a bit of a struggle that takes years, probably from 5 or 7 to 20 years of drug development until you see some drugs being available at the clinic. So what do we mean by translation research? Simply, you take something from bench to bedside. It sounds easy and simple, but it's not like that. It takes years of effort and also billions of dollars to really come up with a single molecule. What we aim by that, there are two aims or three aims: therapy, diagnostics, and also prevention. I'm gonna focus more today on the therapeutic aspect of translational research. What we mean by therapy is to develop a new drug for a certain disease or neurological disease and try to target a certain target in the pathway, specific pathway. Then you hope for advancing it into clinical trials. Sometimes we tend to use translation research also to repurpose the use of existing drugs, and you will see some of the repurposed drugs in the coming slides, inshallah. The diagnostics also is very important in neurology, but it's not my focus of the talk today. So what we mean by translation research, we know it now, the stages of translation research. If you can see from the figure on your right side, it goes through stages, and going through one stage is compulsory. So we start with the preclinical aspect or preclinical stage. So this is what we do, like what we call from bench side. It's you do your preclinical research. It's either be in vivo or in vitro. And in this stage, you assess many things, including a mechanism of action, the safety profile, the pharmacokinetic profile as well, and whether this drug is efficacious in managing the disease that you're targeting. Afterwards, you go through the clinical stages, starting from the first phase, which is you use a small population of healthy volunteers to assess whether this medication is safe to use in humans. You start with a small size or a small dose, then you go a little bit, increase the dose to make sure that the drug is tolerable to human beings. Then after that, you choose a larger population of patients, and you assess the target population or those who are suffering from the disease, and then you increase the dose. Once you continue with all of this, you continue the safety and the efficacy assessment. Then you go to the phase 3, you use it for more stringent studies in which you use RCTs, multi-center, to make sure that the drug is efficacious in a larger population. Afterwards, you get the approval from the drug authority, whether here in Saudi or in the US or anywhere in the world. And then after that, you come up with collecting the data after getting it approved from the drug authority. This is simply the stages of translation. Now we want to talk a little bit about neurological disorders. I don't want to overwhelm you with this slide, but simply there are so many neurological disorders that needs months to really talk about. But the key thing to take from this slide is that neurological disorders has an impact on the people's daily life. It leads to disability and dysfunction of the normal daily routine, and some of them lead to death. As you can see in the slides, the stroke-related issues, the Alzheimer, and we have pain and MS being the most commonly seen in many communities. So today I will be switching gear a bit to give you an example about translational research with one topic, which is pain. Pain is one of the things that most of us experience at some point in our life. And not only the issue with pain is, the main issue with pain is that it's now going, the statistics is showing that there is an increase due to the population growth and also aging, and the quiet prevalence of neurological disorders. So chronic pain is one of the things that is really has a huge impact in the public health, and it has a huge burden on the healthcare providers. So all of us as pharmacists, we know what the pain management is. Mostly opioid is known to be very effective in managing acute conditions, and it gets worse when you use it, and it does not really work when it's become the condition as being neuropathic or chronic. Then we have the NSAIDs, and we have some repurposed drugs like anticonvulsant and antidepressant. So the story with analgesics is very tough. The advancement is very limited due to the difficulty of understanding the neurobiology of pain and pathophysiology of pain. Still, we could not pass something that is more efficient than opioids, unfortunately. Opioid has been known for millennia to manage pain. NSAIDs are very effective in managing inflammatory condition. At some point, it does not work. The main issue with the current analgesics is the limited efficacy in many pain conditions, especially neuropathic pain. And we have tolerance that we see in most of the analgesics. So the need is really necessary to really develop new novel analgesics with improved safety profile. If we cannot manage something that is better than opioids or NSAIDs, at least to the level of opioids and NSAIDs, but with tolerable and acceptable side effects. Generally, being a researcher, we tend to target certain areas of the pain pathway or any of the disease pathway. Like if we talk about antibacterials, we target certain life cycle of the bacteria or the virus. Here, we do the same thing. By understanding more of the pathophysiology of pain, we can really target certain aspects of the pain conditions. As you can see in the left side of this, there are so many targets of the pain, and there is a huge advancement in our understanding of pain biology. Really, there is, in the last 30 years, we've seen a significant advancement in our understanding due to the advancement in biotechnology and how we perceive pain. Pain generally can be divided in two parts, and these two parts have certain areas of that we can target, from the periphery up to the central nervous system. At each point here, we can really target certain areas that we think it can disrupt the pain signaling or pain processing to be and minimize the pain signal. So the current translation research over the, let's say, 50 years, there have been some effort to really develop new analgesics. So I'll give you one of the examples that was like a little bit of a trend in the late 80s and early 90s, which is their discovery of the substance P involvement in pain. They found out that substance P is very important in managing the pain signal processing, and they came up with an antagonist, neurokinin 1 antagonist, and it was very successful in preclinical trials, in different pain models, and also was at the early stages of clinical trials was very effective. But once was tested in real pain condition in phase 3, it failed miserably. And that raised the question that we still need to understand more about pain and how it's been processed. So this is also an overwhelming slide as well, but you don't have to worry about the abbreviation and so on and so forth. But there some work has been under development, almost 200 molecules being developed. Some of them are discontinued, some of them still in phase 3. Some of them, the companies that are developing are not interested in showing their result yet. So are we getting anywhere? I think we are getting somewhere, but still a long way to go. I'll give you some of the depressing statistics regarding the development of analgesics. So this group, screened all databases to see for new molecules being developed, and they found out from the year of 2000 up to 2020 there was around 400 molecules being developed, and they found out the probability of successful rate of taking a medication from bench side to clinical trial up to its final approval is 13%, and 7% for the drug that is aimed to manage neuropathic pain and has no abuse potential. The 13% is still opioids, so we cannot avoid the use of opioid. Is still something that we cannot avoid. So nowadays, the pain management or the drug development is largely shifted from neurotherapeutics to reformulated existing ones. So the question is that you may ask, why so many developed analgesic fail? There are many reasons that we'll discuss it with you now. The preclinical aspect is one of the biggest issues with pain, and the clinical aspect. We'll start with the preclinical one. As if you want to ask me how can I assess this drug is analgesic or not in animals, we have models for animals. You give an injection of an irritant like formalin in the animal's foot, or you give thermal heat, or you give a mechanical pressure on the animal's foot, and you see the response. So this is for the acute ones. There are some assays for inflammatory and some assays for the neuropathic pain, but generally they rely on reflexive measures. What we mean by reflexive measure is if you touch the paw or something, the animal will remove its paw from the irritant or keep licking. These are the reflexive measures. Some of the reflexive measures are not only spinal. They're not central, so you have an issue with the signaling pathway as well if you want to test a drug that you want to reach the central nervous system where the pain is processed. So you have the predictive validity of these molecules. This is one of the biggest issues because pain is not just a somatosensory issue, it's a somatosensory and emotional experience. So in animals now they're trying to have like a more of a predictive measure, trying to incorporate new surrogates for emotional pain, like the facial expression, the grooming, and stuff like that in animals. Of course, poor experimental design, it's a very big issue in preclinical research, going from 3 animals to 10 to 12 animals per group does not give you any indication or for future use because of the weakness of or insufficient statistical power and also lack of randomization. Being someone who worked in the lab for years, I can see students who are trying to p-hack. So whatever they choose, the positive results and try to publish it and graduate as soon as possible. This has a huge impact on the translational research. This is a simple thing. Sometimes I don't see a very, the intention to do the experiment probably is different from one person to person. Human beings generally tend to shortcut things, so they don't want to do things as it should be. So this is one of the things that you see most of the time, that there is a huge issue with the statistical analysis used in preclinical trials. Obviously, the animals that you use, as the variability increases, like human beings, you use animals like mice and rats. They're not the same. You see them, they're white mice, but they're a different strain. They have a very different response to the irritants or the painful experience. And also they have a very different response to drugs, especially to opioids. We have issues with the strain, inter-strain between mice. Black mice are very different from white mice. So it has to be, and the way they respond to the treatment is different as well. Age, mostly we use adult mice. But for people who are suffering from pain, they tend to experience pain at older age, like from 40 and above. So at husbandry, any change in the husbandry, like what we mean by husbandry is the housing of the animal, the temperature, the person who was doing the experiment, because these are prey animals. They are afraid of everything around them. They tend to hide pain. So this is one of the things. They release endorphins to hide pain, and that will have some confounding factor on our reading in doing the experiments. Obviously, the PK profile, differences between humans and animals is a big issue as well. So the clinical, obviously, we still have some issues with the experimental design. Some companies, they by the end of the experiment, the clinical trials, they face some economic issues, so they shortcut. So they tend to use suboptimal experimental design. We sometimes target wrong population. Sometimes you have an off-target effect. That's why the difference between animals and humans show when you see an off-target effect. Insufficient dosing to target our target. The subjective manner, we use a visual analog scale, and there have been some improvement in that, but still a very subjective experience. With all of that negativity, we still have some hope. We have, like biologics, started from the early 2000s up to now. There is a huge advancement in that, and it has been showing to improve the quality of life of many people, but it still is suboptimal. We need a treatment that can cover all population of patients. The example of the TNF-alpha NGF inhibitor has been recently approved for migraine. For the GCP, calcitonin gene related peptide, has been proven for migraine, which is a very good topic to really investigate, and not only rheumatoid or migraine, but also in other pain condition. The gene therapy as well is in process now. We're hoping that VM202 would be a great help, especially for those who are suffering from diabetic neuropathy. The question now is how we improve the translation research. Since we mentioned some of the problems and challenges, the first thing is to really understand that the limitation of the research in general, and the failure is expected, but by improving the experimental design in both preclinical and clinical studies will really minimize the failure. Also, we tend to use a variety of pain modalities, especially in a preclinical stage, use different for acute, chronic, neuropathic, and use something that is surrogate to the emotional aspect of pain. We ensure something that is lacking, especially in labs, which is the reproducibility. We should not be very happy seeing a positive result in one time. You should repeat it in the lab, in different lab. You use a CRO to make sure that your results are legit, and test it in different fields, so in different labs, to make sure that what you have is true, because you are using a small sample size. And I'm not against using a small sample size because it's very costly, labor intensive, but to get around all of that, you need to repeat your experiment at least 3 times in your lab and a couple of times in other labs. And improve the generalizability by considering also the age and sex, because in animals as well, you have issues with how male and female animals respond to pain and respond to treatment. And we see this again also in humans as well. To wrap up my talk, the summary for this talk is we know that neurological disorders is one of the challenging field to have research and try to manage due to the inadequate translation research. We need more advancement in modeling, especially in the preclinical research, and especially this is for those who are doing research preclinically. It's very important to think about not to copy paste whatever has been done, but try to think and invent a new modeling that could be helpful to increase the translatability of our research. There are also some promising candidates for many neurological disorders, like what we explained in pain field, and that is due to our understanding of the neurobiology of many neurological disorders. This is a further reading if you are interested in reading more about translation research, especially in pain. Wrap up this talk by acknowledging the organizers and King Khalid University for allowing me to be here with you, and I'm ready to hear from all of you, your questions. Thank you very much.
I would like to thank Dr. Yahya for this interesting and formal topic. And now we'll open the panel for discussion. Any questions from the audience? Please.
Assalamu alaikum. Assalamu alaikum. Thank you very much, Dr. Yahya. That was an excellent presentation of truly what I believe is an underrepresented research area in our profession. I have a question that keeps wondering and circling in my mind for years now, especially after the burst of CGRP antagonist in migraine and headache pain. And now we see these molecules were approved for migraine, but now they are approved also for cluster headache, and they are getting much more approvals for new indications, as you said, repurposing of these molecules. So my question perhaps is, why do we see a very delay in such expansion or emergence of new medications in pain and Alzheimer, for example? So before the CGRP antagonists were approved for migraine, there has been almost more than 20 years of silence, regardless of the depth of understanding of the pain transmission in humans. So to be honest, I don't know why we keep getting the oncology medications, they keep reproducing on almost a yearly or bi-yearly basis, but not for any neurological disorders, Alzheimer, pain, Down syndrome, despite the depth of understanding of these neurological disorders. Same goes for the rare diseases, but the rare disease is just a different story because the few number or the short number of subjects that these medications can be experimented on. Thank you very much.
Thank you, Dr. Abu Bakr. Simply, the answer is lack of funding. So they tend to fund cancer research more than pain and neurology in general. They increased the funding by the year of 2010 due to the pandemic surge of opioids, but that's gone down. If you remember the figure that by the year of 2018 and 20, the development of new potential analgesics has been going down. So clearly there is an issue with funding, and it's a bit tiring. So it tend to takes years to understand, and also our understanding of pain is still an issue. In cancer, you have signaling pathways that you can target. You see clear indication right away whenever you use it in animals or in humans. But the psychological aspect of pain and all psychiatric disorders, still you have the emotional side that cannot be mimicked in animals. So you get exposed whenever you take it to the clinical trials because of that. Thank you.
Any question? Okay, maybe I have yeah, I know. Maybe I have one more question for you, Dr. Yahya. What are the main challenges in research regarding the chronic pain or treatment of chronic pain? Is there any obstacles similar to what you mentioned? What kind of problems that we face during the preclinical and clinical phases of the studies? Yes.
In addition to the one that I added, generally, like the need to understand more about the funding is one thing. That's the biggest challenge. Whether it's in Saudi Arabia or anywhere, you have an issue with funding because it takes a lot of money to do the experiments in the labs, especially the use of animals is very costly. The main challenge is really how to find the magic bullet model that can grasp all the aspects of pain. So there are so many trials and models now that they do let's say, neuropathic pain. They inject something chemically like vincristine to cause neuropathy. And with that, they add certain surrogates of the emotional pain, like grooming, behavioral activity within the cage, and stuff like that. These are biomarkers that they think it's a bit mimicking the human experience, but still is not really helpful. No.
So since there is no more question, I think we will come to conclude our session today. Thank you very much, Dr. Yahya, for the presentation. Thank you very much. Thank you for all the audience.
Thanks to our moderator and speaker for their great presentation. And now I'd like to invite Dr. Abu Bakr for the recognition. Dr. Abdullah Al-Hameidan. Dr. Yahya Asiri. Dear audience, we have a special gift for you. We will randomly select one of you to be the winner. Are you excited? Cameraman, move the cam. Dear audience, we would like to progress to the last topic for the first session, which is about a promising field in pharmacy practice. The topic is pharmacogenomics, and it will be moderated by Dr. Jihad Al-Ghamdi. Dr. Jihad is the Executive Director of Benefit and Risk Evaluation at the Saudi Drug and Authority. Dr. Al-Ghamdi completed his bachelor degree in pharmaceutical science at King Saud University, his master's degree in medical genetics at the University of Glasgow, and then he received his PhD degree from Glasgow University in systemic medicine. Please let's welcome Dr. Jihad.
Assalamu alaikum wa rahmatullah. Masakum Allah bil khair. First of all, I'd like to thank the organizing committee and the scientific committee, as well as all the people attendance for attending these sessions. As Al-Bandari said, I think this is a very interesting topics to be discussed today. And thanks for the organizing committee for putting this on the program. It's given me a great honor to present Dr. Azhar Arafa, who will speak today as an associate professor of clinical pharmacy at Clinical Pharmacy Department. He obtained his Bachelor of Science in Pharmacy from King Saud University. He worked as a pharmacy degree from North Dakota State University. His PhD in experimental and clinical pharmacology, minor in human genetics from University of Minnesota. Please join me to welcome Dr. Azhar for this talk. Thank you so much.
Assalamu alaikum. Thank you for all coming. Thank you, Dr. Jihad. Since this is the last section before the lunch breaks, I promise to make this short and sweet. Bismillah ar-Rahman ar-Rahim. So we're going to talk today, just going to start with a brief introduction, and then I'm going to move on to define what is pharmacogenomics, what is the goal of pharmacogenomics. I'm going to give some clinical application of pharmacogenomic, real-life application, and then what are the opportunities for clinical pharmacogenomics. So, in the medical field, the main job of everyone in the medical field is to improve the safety first, and then the efficacy of the medication for the patient. Okay, so that's where we get the first do no harm. So, and pharmacogenomics is no exception. The main goal of pharmacogenomics is basically to improve safety and the efficacy of the medication. Using, and this is what is so different about it, is using our genes. If we understand what is the differences in our genes, we can understand why we respond differently to different medication. So hopefully, if we improve the safety and we improve the efficacy, we can move on to hopefully more economical savings. Okay, so currently we are using genetics even before pharmacogenomics, but we use it in a very broad term. It's called race. Sometimes we choose certain medication based on the race of the patient, but this is a very, very broad term, and it's not that accurate. And every time you give a medication to a patient and he's not responding even to the highest dose, you ask yourself why. And even you have some patient at the smallest dose, they get some side effect, serious side effect. And you ask yourself why. And we think, there's probably a lot of reasons for that, but we're very sure that there's a lot of genetic component to it. So, I'm going to give a very realistic example from pharmacogenetic that you can use on your own patient, assuming that you have the test to do it. Okay? I'm not talking about something science fiction, still in the lab. No, it's actually you can use it for your patient if you have the appropriate test. Okay, so let's start with the classic example, warfarin. When you want to study any drug, you have to understand what genes they are affecting, how they are metabolized, what the gene that they're metabolized by, and what genes that can affect their elimination, and so on. So one of the most classic example is warfarin with their gene that affects is called VCORC1, which is the vitamin K gene. And we know that patients with this genetic variation in blue, they need only a lower dose of warfarin, okay? If you are a patient who have this genetic mutation, you need to start them on a lower dose of warfarin, okay? Another example is a metabolizing gene. We all know the cytochrome B450 group. If you are, one of the most important one for warfarin is CYP2C9. We know that warfarin is a racemic mixture of an S and R. Okay, and we know that S warfarin is 5 times more potent than R warfarin. And we know that CYP2C9 exclusively metabolize S warfarin, which is the most potent form of warfarin. Okay, what we know that if you are one of those genotype, for example, the first one, you're going to be a slow metabolizer of S-warfarin. That means you're going to need a lower dose of warfarin. If you are the second type, for example, and you only have one copy, or the second one, you're going to be a very, very low metabolizer of warfarin. Okay, this is relevant to us in Saudi Arabia. You need to do studies to see if these genetic variation actually exists in Saudi population. These studies show that it actually exists in Saudi population. If you can look at the table, you can see the VCOR-C1 on the top and the cytochrome B450 genetic variation on the left side. And you can see that we have some percentages. We know that some Saudi patients will suffer because they have some of those genetic variation. Okay, so it does exist in Saudi patients. Okay, right now, if you can go to this website, warfaringdosing.org, you can get the initial dose of warfarin just by entering all this information: height, weight, drug interaction of certain drugs that the patient is currently taking. This is standard stuff, and you can get a dose. However, what is special about this website, if you scroll down, you can see that you can enter all the genetic variation that we know right now that can affect warfarin. Okay, so if you leave it as is, okay, the website will give you a standard dose with, let's say, 10 milligram. Now, if you have more information, genetic information about your patient, and you plug in, for example, the first one, the vitamin K gene, and let's say the CYP2C9, okay, look at this patient, how these genetic variations is going to affect his dose. It went down almost to half. Imagining starting a patient on 10 milligram where he's supposed to receive 5 milligram only. Okay? Another example, the studies show that the R square basically is showing you how much we understand for using the variation between patient to response to warfarin, using, for example, only age and sex. So we can explain almost 17% of the variability if you have age and sex. If you start adding gene, the picture is going to start become more and more clear. So for example, once we added VCOR-C1 to age and sex, then the explanation went up to 45% of the variation we see among patients. We understand why. Just by adding one gene, adding another one is going to improve it. We can go all the way to almost 60%. Now we can explain almost 60% of warfarin variability among patients using only 3 or 4 genetic variation. Imagine if we have more and more information, genetic variation about our patient. Okay, another example, statins. Statins, the most common side effect, which we always fear, is rhabdomyolysis. What we think is there is a gene, it's called SLC1B1 or OTAB1B1. This is a transporter. Its main function is to move statins from the bloodstream into the liver where it's going to be metabolized. If this gene is not working, that means the drug is free to go to the muscle and cause the damage that usually cause. Okay, so if you did a pharmacokinetic studies on those patients and look for the area under the curve, you can look at the CC. Those patients have what we call the mutant genotype. Okay, so basically they have both copy from their mom and their dad, and that gene is not working properly. So their concentration, as you can see, is way higher than the other 2 genotypes. Okay? So is this higher concentration is translated into higher incidence of rhabdomyolysis? Okay? Yes. If you can look at the left side, the cumulative percentage of patients with myopathy and the years since they started simvastatin, for example, you can see the CC, the same genotype, also have a higher, much higher incidence of rhabdomyolysis compared to the other 2 genotypes. Okay. This is the most important part. Genetic does not affect the drugs from the same family the same way. So you can see that, for example, the SLB1B1 does not affect the statins in the same way. Okay? You can see a variation. That's why it's going to affect in the dosing. If you can take a look at simvastatin, if you are a CC genotype, which is the mutant genotype, you have to take only 20 milligram. Okay? Whereas if you're talking about fluvastatin, there is no change in the dosing whatsoever. Okay? Another example, very important example, is the tamoxifen. We know that tamoxifen need to be metabolized into endoxifen, okay? Using a gene called CYP2D6. This endoxifen, it's 30 to 100 times stronger than tamoxifen when it comes to estrogen receptor affinity. It have a 3 to 100% potent inhibiting estrogen-dependent cell. Okay, so the drug really need to go under this transformation into doxyfen to be active drug. If the patient is not able to transform it, he's not gonna or she's not gonna get the benefit from it. And we know that CYP2D6 have a lot of genetic variation. Some patients have deletion, some patients have multiplication. Basically, sometimes they could have 2, 4, up to 13 copies of this same gene. So we have a lot of genetic mutation in this gene. And just to give you an idea, this drug almost metabolizes almost 25% of the drugs that we use. Okay? So, the patient with certain genetic mutation who are considered poor metabolizer, this is for breast cancer, of course, because tamoxifen is used for the prevention of recurrence of breast cancer. So those patients who are poor metabolizer, that means they cannot transfer the drug into the active form. They tend to have more recurrence of breast cancer, shorter relapse-free period time, and worse event-free survival rates. Okay? So the CPIC guidelines saying that if your patient from this genotype, a poor metabolizer, you should not give him tamoxifen. He should be switched to aromatase inhibitor. Okay? If he's for some reason is not able, cannot take aromatase inhibitor, you need to increase the dose to 40 milligram per day. This is their recommendation, and hopefully this higher dose will, can make a difference in the patient case. Also, another thing we understand from these things, the drug-drug interaction. We didn't give them that, we weren't serious about them that much, but if you give a patient, for example, paroxetine with tamoxifen, and we know that paroxetine is a strong inhibitor of CYP2D6, okay? And a lot of patients for breast cancer, they tend to use antidepressant while going the treatment of breast cancer, okay? So if you give a patient tamoxifen and paroxetine, basically you are inhibiting the CYP2D6, the patient will not get the benefit of that drugs. So another recommendation is never ever give a drug that can inhibit CYP2D6 to the patient who are taking tamoxifen, even intermediate inhibitor. One of the examples is trastuzumab. We know it's also used for breast cancer, but it's only approved for the patient who are HER2 positive, who basically express this protein. However, almost only 15 to 30% of the patient express HER2 positive. Okay, so if you give it to everybody without doing the test, you're wasting this drug almost costs $2,000, okay, for the 600 milligram, and almost $1,200 for the 150 milligram. It's an expensive drug, basically. So if you give it to everybody without doing HER2, you are wasting a lot of resources. You are putting the patient unnecessarily through the danger of side effect from this medication. And we know that it's not going to work for them. So there's no sense in giving them this drug without doing the test. Okay, so as a pharmacist, as a clinical pharmacist in the clinical field, how can I get this information? The best website is called Pharmacogenomic Knowledge Based, or pharmgkb.org. You can go there, type the name of the drug that you are interested in finding any information, pharmacogenomic information about it, and it will give you a list alphabetically of all the drugs that is been studied, and it's going to give you all the different recommendations from different agencies around the world, the FDA, the European, whatever. And it's going to tell you, for Abavacare, the test is required, okay? Another drug will tell you it's actionable, it's informative. And from there, you can click on it, okay? And it's going to tell you what are the genes. And you can, from there, click on the gene itself. And you can choose, if you know the genetic variation, you can choose it and put it there. And it will give you the explanation of what is going on, okay? Those patients are sensitive to this drug. Whoever have this genotype will be at risk of side effect, for example, from this drug, or you should give a higher dose, you should give a lower dose, whatever is the recommendation. But it's there. This is one of the best websites you can go to. Okay, what is the opportunities? More and more hospital every year, every time I look up, the hospital that are implementing pharmacogenomic into their treatment, I found new hospital in the United States actually implementing this technology, okay? And it's a service, and some of those hospitals, for example, Mayo Clinic, they have a company called OneOme. This company's main purpose is to genotype for patients from outside Mayo Clinic. So it's a business. This is an example from the Mayo Clinic. You can see the list of medication and genes that they are testing. This is another called MedClue. St. Jude, one of the most important hospitals that is actually implementing, special for children, the clinical pharmacogenomics. Also, oops, are we done? Okay, so even some hospital right now, they have a PGY2, specialized residency in clinical pharmacogenomics. Even at King Saud University, we started this year a PhD program where one of the tracks is pharmacogenomics. And we are also planning on a fellowship program for pharmacogenomics. So, thank you very much. And if you have any question, feel free to ask. Thank you. الله يعافيك.
Thank you, Dr. Azhar, for this great talks, and it's very informative, concluding your talks about the fellowship program and the PhD, which give, I think, an opportunity for all interested people to join this and improving the education and the human resources and the capability of our practitioners. So with that, I will open the floor for any questions from the audience. Yes.
شكرا دكتور أزهر. Thank you for this nice presentation and the nice topic. Dr. Fagih Abdurrahman Fagih, clinical pharmacist with you. I want to ask about the application of the genotype, especially when we're talking about the guideline, the doses. I think this will change a lot of things in the practicing. Sure. When we take previous about the rice, the guideline, all the guideline there, international with the guideline. New. I think. Sure. Can be
question. Step First, itself in the hospitals, where you need a lab where you can take the blood sample, take the DNA, genotype it, enter it into a certain system. Of course, before that, you need to do some kind of consenting for the patient. There's a lot of law or procedures within the system of the hospital before you can apply this, because DNA is very revealing. Once you give your DNA to any agency, your whole information, your whole genome is out there. So you need to wait to protect it. So start slow with the simple stuff.
I mean the lab cost, the lab test talk costing. I think it is still also other.
Yes.
Yeah.
Yeah, the cost is always a problem. This is the first question: who's going to pay for these tests? Is it the insurance? Is it the patient? Is it the hospital? Is it the government? So, but again, if we prove that this is cost effective, I can justify the extra cost to do the genotyping. If I pay, let's say, it costs me, let's be realistic, if we were talking about in lab, it costs me almost $1 to do a test per patient, okay? It's not gonna be at $1 because you're gonna have to pay salaries and all, but let's say it's that cheap. But you still have to consider that we're not gonna only look for one gene. We need to look at multiple genes. You have thousands of patients, you have hundreds of drugs. It adds up. So we need to find someone who's gonna you know what, if we paid like this amount of money, we're gonna save this much more money.
Thank you so
thank
much.
you, Doctor.
Do you have I think we have more question here. Doctor, do you have question? Already? Okay. Any further question?
Yes, Doctor. Thank you very much. And I know I missed the bulk of your talk, but I always had this question in my mind. Now, we do some genetic testing to see if these some medications are applicable to certain rare neurological diseases such as SMA. And even though if these are very expensive, what is currently happening right now is that some companies are sponsoring these tests. So what do you think, or with time, we generally see a reduction in prices of such services in other than genetics-related tests, but why do you think we don't see such a reduction in the genetic testing techniques? Because even in the realm of diabetes, for example, when we see a patient and we suspect this is kind of moody representation of diabetes, even in the United States, we only had 2 centers to screen for moody genetically. But my question for an expert in your place, why we don't see such reduction in the cost of these testing, and we don't see with even time, 10, 15 years, we don't see any difference, either in the diversity or where these genetics are being done, or how much it costs.
Actually, the cost is going down dramatically compared to the first human genome we did, which is around like $2 billion, okay? Because they were, anyway, but these days I can do a whole genome sequencing for almost $200. So the cost of genotyping is going down very, very fast. The problem is still, even if it's cheap, who's gonna pay for it? Is the hospital are ready to use this technology? Do you have the manpower to apply it? Is the mindset in the hospital ready? Can your staff actually apply that? For example, if I have this information inside the computer in front of the pharmacist, but he does not know how to use it, is it going to be useful? No. If the doctor does not know how to interpret this data, is it going to be useful? No. If the patient himself does not understand how important this information is, he's going to ask from us to, can you please genotype me first before you start this medication? I read this and that on the internet that you need to do a certain kind of genotyping. So you need the mindset first. But the cost of genotyping is going down dramatically. It's nothing compared where we started from.
Just another question, I'm sorry. Where in Saudi does people who are interested in genetics can proceed with research or start their research journey in pharmacogenetics or genomics?
Patient or student, academician?
Students and academics.
Okay. Right now in King Saud University, as I said in the presentation, that we started a PhD program that one of the tracks can go with pharmacogenomic. If, for example, if you're studying with me or Dr. Maha Rashid, for example, or Dr. Ghada Buhaymet. So there's like few of us who are specialized in pharmacogenomics. So we can have PhD program student join us. We're planning on starting a fellowship program. Right now at King Saud, in the new PharmD program, we have a course called Principles of Pharmacogenomics. Also, we have an elective course, it's called Advanced Pharmacogenomics. So I think I taught in the Faisal University, but it was elective pharmacogenomic course. But that's it from what I know about pharmacogenomics in Saudi Arabia.
So thank you very much.
You're welcome.
Thank you. Thank you, Dr. Azhar. For the sake of the time, we have to conclude our sessions. I would like to thank you, Dr. Azhar, for your great talks, and also thanks for all the attendance. And I think we do have a break now. Thank you so much.
Thanks to our speaker and moderator for their informative discussion. And now I would like to invite Dr. Badr Al-Ghamdi for the recognition. Dr. Jihad Al-Ghamdi. دكتور أزهر عرفة. Dear audience, we have another special gift for you. Excited? Where is the cameraman? Or I will be the winner, otherwise. dear audience, kindly note that we are going to take our prayer and lunch break, and we will meet you again to proceed with our next sessions at 1:30. Thank you.
today, which include first cardiology and oncology. I am PharmD candidate at King Saud University. Our first topic is critical care, and we all know how crucial this specialty. It's my pleasure to introduce you to our moderator. Al-Harbi is a consultant critical care pharmacist. University, he's done his BGY1 and BGY2 in critical care at King Saud Medical City. Dr. Al-Harbi is an American and Saudi board certified in critical care pharmacotherapy and co-founder and board member for pharmacotherapy chapter at Saudi Society of Critical Care. Currently consultant of critical care clinical pharmacist at King Salman bin Abdulaziz Medical City in Medina Munawwara.
Thank you, Dr. Abdurrahman, for this nice introduction. Welcome everyone for this IHOP critical care session, and nice to meet you all. Hope you will enjoy such great session. And without any further ado, let us start with the first presentation. Updates in septic shock management will be presented by Dr. Bassam Al-Khail. Dr. Bassam graduated from College of Pharmacy in Al-Qasim University with PharmD degree. In 2017, he started the residency program of General Clinical Pharmacy at King Fahd Medical City for 2 years. Then he completed the specialty in critical care from King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Al-Dakhil got the American and Saudi board certification in critical care pharmacotherapy in 2020. He also certified as ECMO clinician by Extracurricular Life Support Organization. Please join me to welcome Dr. Al-Dakhil.
السلام عليكم. أعتقد الصوت واضح إن شاء الله. Good afternoon everyone, and thank you for the organizing committee to give me the chance to be here and to be presented in IHOP 2022. The majority of us, or the majority of audience, when they read the title New Update in Septic Shock Management, they thought that the presentation will be focused on the new released guideline on septic shock. But as the title of IHOP 2022, that moving to the future, I try to match that theme and to think or talk about something that have the potential to be changed or change our practice in the future or in the next years. So the objective of my talk today we'll discuss about the place of renin in septic shock management and how that will change our practice in the future. Also, we'll talk about the role of hydroxycobalamin in septic shock management and to evaluate the end of IV cocktail that has been taking too much talk in the past 7 years. So as we know, sepsis is a clinical syndrome. It's a life-threatening organ dysfunction caused by dysregulated of response to infection, where a septic shock is a subset of the sepsis, where a severe dysregulation and disturbance at cellular level or metabolic level, and it's been known as a severe hypotension or persistent hypotension despite fluid resuscitation. Also, the requirement of inotrope or vasopressor to maintain the MAP above 65 with the lactate more than 2. So just a quick review about the common pathophysiology of septic and of sepsis and septic shock. The ideal of this graph, as we can see, there is always a human response or inflammatory response to a triggers or toxin, mainly from a bacterial or microorganism. And that trigger will lead to release of a huge amount of interleukin 1, 2, 6, tumor necrosis factor, interferon, and that will start to activate the complement system and leading to the inactivate our cellular immune response, leading by B cells and neutrophil, to reach to the end where the humoral immune response take over and leading the disease state by releasing the immunoglobulin. As we can see in the lower side, there is the way that how our body will defend and try to maintain our function or our system or our hemostasis in our body. And that's defense actually working by boosting our immune system, by counterattack the huge inflammatory response that happens because of the triggers or the toxin. And the common or the majority of therapeutic option for septic shock is lying actually in that picture. Because the majority of our therapy that we have right now, either by suppressing the inflammatory process or by boosting the anti-inflammatory process and try to achieve the cure. If our body fails to boosting our immune system, the death is the final result. So despite sepsis and septic shock is very old disease, has been discovered many years ago, globally still the cases is very high, reaching around 31 million annually, and with a 5.3 million death annually despite the advance in management. In 2014, a great paper being published by our colleague Dr. Arabi demonstrate and state that despite the advance in modality of diagnostic and therapy, still there is a dramatic increase in number of sepsis, reaching around 8 to 13% annually. And as by the Ministry of Health report in 2017, the number of sepsis and septic shock cases reported to be around 128,000 per year, with 64,000 mortality annually. So, moving to the first objective of the talk today is what is the role of renin in septic shock and where is renin lying in the management of septic shock. So renin is a common enzyme that has a major role in the RAS system, where it is needed to convert the angiotensin gene to angiotensin 1, where the angiotensin converting enzyme take over there and converting angiotensin 1 to angiotensin 2, which bind to angiotensin receptor and lead to multiple mechanisms to maintain our hemostasis in our body. As we can see in the picture, where vascular mobility, cell growth hormone, and also a tissue repair and remodeling. And this is, we can see, in normal situation where the hemostasis is being maintained, as we can see that the trend is following and maintained to maintain our body function and to maintain our hemostasis. Unfortunately, when there is a severe injury or severe stress, as happens with the severe shock or septic shock, there is a disturbance in this hemostasis and in this balance that lead to increase the number of renin, which lead to decrease the number of angiotensin converting enzyme, leading to a misbalance between angiotensin 1 and angiotensin 2, and to disturb this hemostasis in our system. And from that thought, or from this idea, the idea came for the synthetic angiotensin 2 drug that may help or reduce or to restore this hemostasis to achieve a cure in our patient. So, unfortunately, there was a common or well-known study named ATHOS was published in 2018 tried to test the role of the new drug synthetic angiotensin II in septic shock. And the outcome of this trial, they found there is no significant differences in the outcome when we add angiotensin to the medication. And this was in 2018. In 2020, there was a very interesting paper that has been published in 2020, looking for a different type, analyze the data that has been published in Athos trial in 2018. And what they do here in this trial, they include all the adults with a vasodilatory shock despite volume resuscitation, requiring high-dose nor-Epi, and they were assigned randomly 1-to-1 ratio to receive synthetic human angiotensin II or placebo. And what they do in this study, actually, they look for the renin itself and to see is there a difference if we target a different type of patient or we use the angiotensin II for different type of patient. And they split the type of patient to two groups: a patient where a renin is extremely high, above the normal level, and the group where the renin is normal or on the low level. And they try to see is the outcome will be different at those patients or at this subtype of patient that not being represented or offered or being analyzed or looked at the Athos trial. And the interesting point here, they found that the 28 mortality was significantly drop or decrease with the patient with the high renin who received the angiotensin II. Also, the length of ICU stay was decreased in those patients, and also the ventilation days was dropped in patients who have a high renin and receive the angiotensin II medication. And as we can see here in the Kaplan-Meier graph, that the survival probability is significantly less when a patient is not receiving with a patient not receiving the angiotensin II with a high renin, as compared to patient has a better survival who receive the angiotensin II with a high renin. And this was a very interesting point, that the majority of the way or the recommendation that came in every day or every year or in a quarterly, they look for a general patient, and we used to generalize our statement in general patient. We are usually not looking for a subtype of patient or subgroup patient they may get benefit of the angiotensin II. And this trial started to be a common theme of talk in the 2022 conference around the world, to see maybe there is a hope with angiotensin II that may benefit our patient. And moving to the second point, what is the possible role of the mega dose hydroxycobalamin in septic shock patient? The first time I read about the topic, I was surprised to see what actually the role hydroxycobalamin may play in septic shock patient. And when I got the chance to read about it in details, I was surprised that there is actually a potential target therapy that's been hidden from us, and we didn't have the chance to investigate and to elaborate about it or talk about it in our daily session or talk. So when I look to why we think that hydroxycobalamin may play a role, there is a common pathways in our system where a severe vasodilatation or vasoplegia happen in our refractory septic shock patient. Those both pathways, they go through the nitric oxide or hydrogen sulfidase that lead to activate the cyclic GMP or the potassium channel to lead to the severe resistance refractory hypotension in our system. And the hydroxycobalamin has a major role to interact and interfere with these pathways to prevent and decrease the vasoplegia in our system. And the first idea or the first hint about the possible role of hydroxycobalamin has been published in 2021. It was a case series evaluating the efficacy and safety of hydroxycobalamin in a patient with a refractory septic shock despite fluid resuscitation and high-dose inotrope. And the interesting what they found in this case series, they found that, as we can see in the left graph, that MAB after the giving patient hydroxycobalamin or mega dose of hydroxycobalamin is increased dramatically over time, where the inotrope or vasopressor requirement in the right graph is dropped dramatically in those patients. And this actually, the paper, it triggers the IHOP trial group to look, is there a possible role of hydroxycobalamin in our patient or not? And what they do in this study, they do a randomized controlled trial. They do it as a pilot of 20 patients in a way to test this hypothesis to see, is it feasible to be done? Is it safe to be done? And is there any initial beneficial outcome in those patients? And they include all septic shock patients who require a high dose vasopressor. And what they do, they try to assess the hydrogen sulfide level and to see any correlation with the clinical outcome, which was the vasopressor requirement. And the interesting in this study, despite it's a pilot study, they found it's very feasible to use it and give it in our patient. It's safe, as they report a zero side effect on those patients. And when they look for the level of sulfadiol or hydrogen sulfide in those patients, they found a significant drop that to the clinical outcome, which was mainly the requirement in general. And the official study which is ongoing right now. And actually I can hide that I'm very excited to see or read the paper in the next year, because it seems very interesting and it seems very promising in a way how we manage. Just published around 1 month and a half ago. So reaching to the final part of my talk today is what about the IV cocktail and septic shock. It's a very old one. It has been the common talk in the ICU. It's barely, you never have any educational discussion in the ICU unless someone will jump and ask you what you think about the IV cocktail. Is there any possible benefits of the IV cocktail in the ICU or not? And the idea started in 2016, where Mark and his colleague published a paper talking about the combination of vitamin C with hydrocortisone and thiamine that in septic shock patient that lead to a 40% drop in mortality. And that was the bump was published in 2016, where lead everyone to talk about what's a magic combination that in the ICU. Unfortunately, a multiple study has been published after that. A well-randomized controlled trial try to test this hypothesis and to see is actually there any benefit or outcome. And unfortunately, the three most common RCT that has been published, and all of these RCT found no benefit of IV cocktail in the ICU. But despite that, the hope still exists around the ICU clinician, and they said, okay, there is no benefit, but why wouldn't give our patient the benefit of doubt and to use the IV cocktail, as it's just a vitamin C and the risk and the safety profile is high. So let's give our patient the benefit of doubt. Until recently, 2 months ago, there was a Lafayette trial that has been published in the New England Journal of Medicine. And what they do, they replicate the study from the previous trial, and they try to see and test again the hypothesis of the IV cocktail. And the interesting outcome in this trial that they found the composite outcome of death or multi-organ dysfunction was actually increased in the IV cocktail compared to the placebo group. And that was the end of the story or struggle of the IV cocktail in the ICU. And that actually should push us a little bit away from using the IV cocktail in the ICU, and we should be careful when we use the benefit of doubt concept, because it's not actually a safe intervention to be in the ICU. So to end my talk, this is the talk take-home message that I would like to mention at the end. We have to be innovative in our care, and the world actually now are moving to a more individualized medicine. And the common statement that has been released about general patient. Well, and we manage them as a general patient, and we miss the opportunity to provide a better outcome or to achieve a better outcome in those patients. And we should push ourselves to look to those patients and to be willing to investigate and manage them accordingly rather than using the general statement in our patient. One important thing while I'm doing this research, I wasn't planned to make it as a take-home message, but while I'm reading and preparing to this talk, I found that really actually understanding the pathophysiology at the micro level, there is a many and plenty of potential target. And there is a lot of potential target that we are not investigating and we are not looking at. And we are missing the chance of delivering and decreasing the mortality in septic shock patient. And we need to look at that separately because this is actually the future. The concept, benefit of doubt, is not necessarily a safe concept. And we need to be very careful with this concept because not every intervention is safe, is guaranteed safe. We don't know what the future will hide for you. By that, I end my talk and thank you.
Thank you, Dr. Bassam, for this nice and informative presentation. Now we'll move to the next presentation, BCC versus Andexanet Alpha for DUAC reversal, will be presented by Dr. Saleh Al-Zahrani and Dr. Namarik Dahir. Dr. Saleh is a clinical pharmacist working as an adult critical care clinical pharmacist at Security Forces Hospital. He earned his PharmD degree from King Abdulaziz University in 2009. He has done his BGY1 in clinical pharmacy at Security Forces Hospital and BGY2 in critical care at King Saud University in 2022. Dr. Al-Zahrani became an American and Saudi board certified in critical care pharmacy. Dr. Namarik also has earned her PharmD degree from King Abdulaziz University, completed BGY1 at King Faisal Specialist Hospital and Research Center in Jeddah. Also, she completed BGY2 residency in critical care specialty at King Saud University Hospital. She earned 3 American board certification in pharmacotherapy, critical care, and nutrition support. She has a total of 9 years experience between pharmacy services and clinical work. She is also a critical care clinical pharmacist currently working at King Faisal Specialist Hospital and Research Center in Jeddah. Please join me to welcome Dr. Namarik and Dr. Saleh.
السلام عليكم جميعا. Thank you Dr. Ahmad for the nice introduction.
and thank you for the scientific and organizing committee for this great opportunity to share the stand here and to discuss the major issues in ICU with such colleagues. So we're gonna start, but before that, Dr. Namarek and I both wouldn't have any conflict of interest to this matter. And here are our objectives. So we're gonna focus on the three main aspects of the differentiations between the prothrombin complex as well as the andexanet alpha. So we're gonna focus on the safety, we're gonna focus on the efficacy, and eventually we're gonna end up with discussion about the cost. So briefly, before we go into the medication itself, so let's explain a little bit about the PCC or the prothrombin complex. So majority of us will have at least a little knowledge about what's the PCC or the prothrombin complex concentrates. It's a concentration that already approved by the FDA for reversal of the vitamin K dependent factors. So it's going to increase the concentration of the vitamin K dependent factors as well as protein C and S. It's available in different products as Kcentra or in many hospitals as an Octaplex. It has different half-lives, which range from 2 up to 6 hours and sometimes up to 72 hours based on factor 2. Dr. Namarek?
Thank you, Dr. Saleh. So today I'm going to present the andexanet alpha side, and when we're talking about andexanet alpha, we're talking about an antidote that has been approved in 2018 for the management of life-threatening bleed caused by apixaban and rivaroxaban, and we do know that we are using these two medications a lot recently. So it has a half-life of around 3 hours. It depends on the dosing, but as a pharmacist, we do care about how this medication is prepared, this new antidote. So it's a kind of antidote that has two strength, 100 and 200 reconstituted, transferred to the empty bag, and then we need a filter when we do administer this medication. Its stability is around less than 8 hours after reconstitution. Talking about the mechanism of actions of andexanet alpha in general, we are talking about an antidote that I do call a cheating drug. So it's just like a factor 10A that comes to our body that deceiving the already their apixaban and rivaroxaban. So it's just like telling the apixaban or rivaroxaban in the body that, you know, I am there. So it has a very high affinity. So these medications bind to it and leave our factor 10A, the human factor 10A alone. So it's the coagulation cascades continues, and then the thrombin and fibrin productions, it's formed. So it has another pathway that it uses other than deceiving the rivaroxaban and apixaban by making factor 10A. It also inhibits the tissue factor plasminogen inhibitors, which is usually inhibit factor 10A. So by inhibiting the inhibitors of factor 10A, so that means that we have more of the thrombin productions because our human factor 10A is free to be used. If we want to compare our mechanism of actions of andexanet alpha compared with the 4-factor BCC, we know that this medication, or 4-factor BCC, which is this coagulation factor, usually it works by giving the factors, the vitamin K dependent factors. That's why it's a kind of an antidote that is drug of choice for the warfarin reversal. But if we give factor 10 and then the factor 10 produce the factor 10A, the rivaroxaban or apixaban is still there. So they might even bind to this newly formed factor 10A. So we have this luck that we are giving a lot of factors. We want them to work to the coagulation cascade to form the thrombin. However, the real drug or the causative drug is free and is still in the body and it's not touched. So if we want to think about the efficacy of those two medications, we know we need to measure this efficacy, and that's what we're going to do. So how we are going to measure the efficacy of factor 10A or the 4-factor BCC? Usually in the trials, they do measure the efficacy of factor 10 of andexanet alpha by the anti-factor 10A activity. Some of the studies, they look into the thrombin production for factor BCC. However, for both, they are looking to something called the hemostatic efficacy, and that's what we want to focus in here. So if we want to go to the first trial that has approved the andexanet alpha, so this trial is an EXA trial that has been published in 2016, and in this trial, they aim to use the andexanet alpha for the life-threatening bleed. 352 patients, most of them AFib patients. They used apixaban, rivaroxaban, and also indoxaban and enoxaparin, but we're not really going to talk about them much today. And then they were looking about the anti-factor X activity and the excellent or good hemostatic efficacy. So how are we going to define the bleeding first? They define the acute major bleed as any bleeding cause hemostatic instability or decrease the hemoglobin by 2 gram per deciliter or more, or acute bleeding in the critical or vital organs. So intracranial hemorrhage is one of the places that considered as life-threatening bleed. How did they define the excellent or good hemostatic definitions in general? So if for intracranial hemorrhage, less than 35% increase in maximum hematoma thickness, that's good, a great hemostatic efficacy. And for the GI bleeding, less than 20% decrease in corrected hemoglobin and hematocrit, that considered as a hemostatic efficacy. These two definitions, we are going to use it a lot all along the presentation. So we need to define the efficacy for the medications. So what did they find? Anti-factor Xa activity after the end of bolus have been decreased by 92% and continues to be decreased in general with a lesser extent up to 12 hours after administration. When we're talking about the hemostatic efficacy in general, it was decreased almost 80%. Good, I'm talking about the excellent and good hemostatic efficacy is about 80% at 12 hours. So that was an effective drug. So 2020, there were a comparison between 4-factor BCC and ANEXA. So when we're talking here about a retrospective study that looked into those patients and with intracranial hemorrhage, very small number that the pre-reversal level of 4-factor BCC was around 37 ml, and post-reversal level double compared with andexanet alpha, who was 20, and when it increased only by 2 mLs. So that could consider that's considered an efficacy. And when they looked into the hemostatic efficacy, andexanet alpha was higher than the 4-factor BCC. Another study in 2021 also compared. It's all single centers, retrospective studies, a small number, I know, but all of them or most of them, they have the same finding. Stable head CT at 6 and 24 hours, and when we looked at here, hematoma at 6 hours and hematoma at 24 hours, it was not really statistically significant, but as you can see that andexanet alpha has a higher stability of the CT at 6 and 24 hours. So it's, as you see, it's an effective drug. Again, 2022, another study, they were looking also in comparing the andexanet alpha and 4-factor BCC, and please concentrate in the dosing. They mostly use the low dose for 4-factor BCC, for andexanet alpha, and for the 4-factor BCC, 79% they use the 25 unit per kg, and we know that there is a range for this dosing. Hemostatic effectiveness, again, as you can see, the baseline volume compared with the repeated volume was much higher in the 4-factor BCC. So again, hemostatic effectiveness favoring the andexanet alpha. Dr. Saleh.
So we're going to start with some evidence that supports the use of prothrombic complex in critical care patients. So we're going to start with this trial, which conducted in 2019, and they will look in retrospective manner about who those patients received the PCC. So they include around 31 patients, and the majority of those patients were having atrial fibrillation. So the PCC here were used in different dosing regimen, but more than 50% of them, they used the prothrombic complex with a dose of 50 units per kg. So in terms of the primary efficacy endpoints, so it was achieved, or the hemostatic effectiveness was achieved in 80% of those population. No reports of the venous thromboembolism, and we look into the in-hospital mortality, it was 16% in those population. Going into the similar study, but this time is a multi-center ones, in a retrospective fashion, and looks into the safety, efficacy, as well as the cost of prothrombic complex in comparison to, just only the PCC, in terms of safety, efficacy, as well as the cost. So a total of 600 patients were enrolled in this study. So they use a different dosing regimen again for the prothrombic complex. And their primary efficacy endpoint was the hemostatic effectiveness, which was obviously that 80% of those population, they have the primary efficacy endpoints. And we look into the length of stay was 2 days. The ICU mortality reported in around 12% of those population. And we look into the thromboembolic events, it was around 4% of those patients. And the majority of those patients have the VTE in the first 5 days of the therapy. Going into the next study, which was systematic review and meta-analysis, include around 21 studies of more than 1,700 patients. So they were comparing between the indexant alpha and between the prothrombin complex concentrates. And they looks into different outcomes. So in terms of the primary efficacy endpoints, which is the effectiveness at 12 hours interval, the hemostatic effectiveness was achieved in 88% of those population who received the prothrombin complex, in comparison to 82% of patients who received the indexant alpha. Again, the hemostatic effectiveness were more achieved in patients who received the prothrombin complex at 24 hours period, 76% compared to 71%. Venous patients who receive the indexant alpha. Another systematic review and meta-analysis of 36 studies looks into, again, the differences between both the prothrombin complex as well as the indexant alpha. So, again, the hemostatic effectiveness in terms of anticoagulation were achieved more in patients who received the prothrombin complex, with slight differences of 77% compared to 75%. For the secondary endpoints, which were the mortality, reported more among patients who received the prothrombin complex, and the rate of venous thromboembolism were reported more among patients who received the indexant alpha. Compare head-to-head between the prothrombin complex as well as the indexant alpha. So in terms of the anticoagulation reversal, again, there was some differences between both the indexant alpha and PCC. However, this finding, it doesn't reach into the statistical significant differences between both. When we look into differences between both the prothrombin complex as well, there was no statistical significant difference. So the second part of this presentation, we're going to discuss the safety profile. So when we look into the different study that's reported the thromboembolic events, so the data here are varied between the different studies. Majority of these studies reported that the higher patients who have the venous thromboembolism were among those who received the indexant alpha. There's only two studies, which the Vestal et al. Reported venous thromboembolism at a rate of 31%, and the FAM et al. Reported more venous thromboembolism among the patients who received the prothrombin complex. When we look into the mortality, again, it's quite evident that the mortality reported here similarly between vast majority of the studies. However, two studies here were reporting that the higher mortality among those who received the prothrombin complex, which is the Para et al. And we look into the Vestal as well, they reported more mortality among those who received the indexant alpha. But if we look into the guidelines itself, the guidelines recommend that when you use the prothrombin complex for factor 10A, you have to use a dose of 50 units per kg. And this recommendation also adopted by different agencies, include the American College of Cardiology, Neurocritical Care, as well as Emergency Medicine. And back again to the studies that reported the higher risk of mortality among the PCC, they use half of a dose. For instance, the Para et al., they use half of the recommended dose, and instead of the 50, the half of the dose. So this is might consider one of the co-founders of the high risk of mortality among those populations. Dr. Namarek?
Thank you, Dr. Saleh. So yeah, so talking about the safety of these two medications in general, so we have a lot of studies, of course, encounter the safety. And when we are looked to the safety, we're not really concerned how much or the number of thrombotic events. We do care about the number, we do care about the time to event, and we do care about which kind of thrombosis that the patients faced. So is it an MI, is it a DVT, it's a PE, or so on. So I have looked into almost 13 studies published between 2015 and 2020. They have followed the patients up to 30 days. And I found that the thrombotic event in patients with andexanet alpha is higher than those of 4-factor BCC, as Dr. Saleh said. And the mortality for those patients with andexanet alpha is Dr. Saleh said. But this number doesn't make sense if we didn't ask the real question, why? Why the thrombotic event in those patients higher and the mortality here is lower for andexanet alpha and higher for 4-factor BCC? That's gonna make a lot of clinical sense. If we went back to the Andexa trial, we have 10% of all patients who have been facing this thrombotic events. 10%, all of them had the thrombotic event before restarting of anticoagulation. So is the timing of anticoagulation reinitiation related to the number of thrombotic events for andexanet alpha? A study of my colleague that has been done in the single center in Boston, they described the anticoagulation reinitiation pattern and the thrombotic events. And they found that the patients with andexanet alpha, they started anticoagulation earlier, so either prophylaxis dose or treatment dose, whatever's. And the thrombotic event for those patients in andexanet alpha group was lower than those for 4-factor BCC, knowing that 35% of the andexa group have also received the BCC. And we know from many cases that more patients, if they receive both BCC and andexanet alpha, they are going to have more thrombotic event, although reinitiation of anticoagulations have prevented that. So another study that in 2022, a multi-center study, also they're comparing efficacy and safety of andexanet alpha, and they found that the anticoagulation reinitiation was higher in an andexanet alpha group, a great correlation between the time about really doesn't make sense. We really know this than those patients with andexanet alpha. Hematoma volume was much higher than those in the andexanet alpha, so that might make sense. And then, however, in another study that has a comparable, hematoma volume and baseline GCS, they died because of the bleeding. And as Dr. Saleh said, that might be related to the dosing of 4-factor BCC. So when we're saying that the mortality is higher in the 4-factor BCC, what we care to ask here is this mortality is higher because 4-factor BCC is not as effective as andexanet alpha? Do we really need to dig into the dosing that's given to the patients? So that's really makes sense. Dr. Saleh?
Thank you, Dr. Amar. So going into the last part of the presentation, this debates, we're going to talk about the cost. So two studies here, they were looking into the direct cost between the two agents. So the prothrombin complex, it costs around 16 up to 17,000 US dollar. And we look into other study, they look into the differences between the BCC as well as the andexanet alpha, and the range was ranging from 16,000 up to 23,000 US dollar. So in addition to that, I can use the prothrombin complex in different indications. I can use it for anti-TNA, I can use it for warfarin as well, and I can use that for dabigatran. In addition to that, if I use the andexanet alpha, I have to look into the anti-TNA level, which is not readily available in all the institutions around the kingdom. So from my perspective, the cost is a major concern here, and the difference is huge when we talk about the 23,000 US dollar.
Thank you. So let's move to the last part of this presentation, which is the cost. costs for andexanet alpha is very expensive. I can't see that. So the andexanet alpha dosing in general, it's mainly about how much the patient took and when it's the last time of exposure, and the 4-factor BCC instead fixed dose versus dose based or weight-based dosing. So when we look to the data, andexanet alpha, with the last price that we have in our hospital, the one vial is cost 37,000. So if the course of the low dose protocol, it might cost 187,000, and if it was a high dose protocol, so it's 337,000. Compared with patients in the 4-factor BCC, who the costs range from 7,000 to 12,000. So when we do this cost comparison, it just came to my mind the concept of the racing car compared with the electrical car. They are all a car, they are all a reversal, but there is one of them that is really specific, it's in the antidote, and one of them is a car that could do the job, but it's not intended for the job. So if we want to see the reality that andexanet alpha everywhere is the drug of choice, it's number one. So we need to, everyone is advising to use the andexanet alpha in all recommended guidelines. And we cannot say because andexanet alpha has a higher cost, so my patients who came with life-threatening bleed, we do not give him this andexanet alpha because it's very expensive. So that doesn't make sense. This is, this is a patient life here, what we are talking about. So if we want to save, so what we're thinking, I want to save. So we could, introduce this factor stewardship program that doesn't really look into andexanet alpha alone. It looks into all the coagulation factors that we're using for hemophilia patients and for others. And for one study, doing the factor stewardship saved up to 4 million annually. And if we want to implement this factor stewardship for patients with andexanet alpha, we need to know that andexanet alpha, that as what we have defined earlier. If the patients already took BCC, so there is no evidence just to use andexanet alpha just because we have it in our hospital. So that need to be put into mind. And another thing, the reversal window. Almost all the studies, they use andexanet alpha after exposure within the 18 to 24 hours of exposure. So if the patients came after the 24 hours, and the anti-factor 10 assay, which is calibrated for rivaroxaban and apixaban, has a very high collaborations with the favipiravir assay that we do have in our hospital. So that's in general. So the question here, would you work on having andexanet alpha in your hospital? Me and my colleague, we brought the evidence, and the decision is, of course, for you. Thank you.
Thank you. Thank you, Dr. Namariq and Dr. Saleh. Please, Dr. Bassam, join us to the podium to start the discussion and questions. I will take the advantage to ask first. Actually, I have a question for all of you, starting with Dr. Bassam. Regarding the angiotensin II, understanding that it is effective in subgroup of population with high renin level, and actually we don't have in our hospital this type of test. Doesn't that make it more limited to be added to our formularies?
Thank you. Okay. Thank you, Dr. Ahmad. This is actually the right question to be asked. I think the majority of our institution here in the Kingdom, they don't have the renin test. And if in our institution, it's a send-out test, which is take, I think, 3 to 4 weeks, which already passing. Yes, absolutely. The question is, do we believe that renin has a role in septic shock patient? If we say yes, I think yes, we need it. And we need to, and it needs to be brought to the administration that there is some advance of patient, and there is, we can select some patient that they may get benefit of using angiotensin II drug. And if we say yes, we need to add renin, I think we have another question to be asked is, do we need to add angiotensin II to our formulary? And this will be another question to be added. I believe that the next sepsis guideline they will highlight the angiotensin role in the future. And after that, I think we have more solid evidence and support to raise it up in our committee or our institution to say there is subtype patient that they may get benefit, and we need to analyze them and treat them as appropriate as it is.
Great, thank you. Now we'll move to Dr. Namariq. Taking in consideration that the cost is 300,000 plus, how gonna you convince the formulary guy to add the Andexanet, especially with knowing that it will not reduce the mortality statistically?
Thank you for your question. Okay, first I'm not the one who convinced the formulary. But of course, by evidence, it's a drug of choice. So this is the medications that it's approved by all guidelines. So the thing is that if our hospital got the money to bring this medication, and any hospital in the kingdom, so the question why we don't bring it if we can bring it, it's a drug of choice, it's the antidote of a choice. It's the only antidote for those patients. So this is one thing.
Okay, great. Dr. Saleh, don't you think that the variety of dosing of BCC limit its use more and give the chance to Andexanet to be added to the formulary and to be used for rivaroxaban and apixaban? And which is the best regimen of dosing for BCC?
To be honest with you, it's a debatable question per se. So if we look into the BCC itself, or prothrombin complex, the dosing were studied whenever you're going to use the doses as a fixed dose, or you're going to use it as weight-based dose. So the doses is debatable. Again, also, if we look into different studies that nowadays is available, it's already published and looks into the different in dosing between the prothrombin complex whenever you received the 25 in comparison to the 50 units per kg as a maximum dose for anti-TNA. And the result was, as expected, that the incidence of, the incidence of thrombosis were more among those who received the full dose, which is the 50. And the anticoagulation reversal and the hemostatic effectiveness were achieved among those patients who received the 50 units per kg. Indeed, it's a lot of questions. Definitely goes with the prothrombin complex. Am I going to pick the weight-based? Am I going to pick the units per kg doses? And if I have to do so, am I going to the highest dose, or am I going to give the dose and looks into other monitoring parameters to guide the treatment?
Okay, thank you, Dr. Saleh. Now we'll open the floor for questions. 5 minutes. And we'll open the floor for questions. Any questions? Anyone have a question? Great. Okay, by this we'll conclude and thank the speaker for this actually excellent and informative session and for effort. Thank you so much. Appreciate it.
شكرا لكم جميعا كمتحدثين ورؤساء للجلسة وكذلك إدارة للجلسة. دكتورة فاطمة تفضلين معنا. حابين نكرمكم، ما ودنا نتعبكم وننزلكم كم مرة. بداية مع دكتور بسام الدخيل. دكتور نمارق الدردير. دكتور صالح الزهراني. مدير الجلسة دكتور عماد الحربي. كذلك عندنا دكتور عبد الرحمن القناص واللي كان رئيس الجلسة. ودك تجلسي معنا يا دكتورة؟ حياك الله. طيب عندنا الهدية الأخيرة لليوم. كنتوا معنا في الهديتين الأولى صح ولا لا؟ سواء كنتوا معنا أو لا، احنا مقدمين هدية بين كل جلسة وجلسة. فكرتها ان الكاميرا راح تدور عليكم، واللي تختار الكاميرا او اللي تحب الكاميرا راح تكون له هدية. فالكاميرا مان عندك الموضوع. تتوقعون من بتكون من نصيبه؟ بس ترى كلكم يلي موجودين لكم نصيب منها. يلا مين؟ شكلكم مسوي حركة ستوب. هذه أحس بتسهل علينا. ألف 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 مبروك. تفضل معنا على المسرح. يعطيكم العافية. طبعا عندنا هذه الفقرة كل يوم 3 مرات تقريبا أو 4 حسب عدد الجلسات، فخلونا نشوفكم كل يوم إن شاء الله. والحين راح نكمل معاكم باقي برنامجنا.
Now switching gear to another important topic with our moderator, Dr. Faisal Al-Garni. Dr. Faisal Al-Garni is a cardiology, clinical pharmacist and pharmacy residency program director at Security Force Hospital. He earned his Doctor of Pharmacy degree from King Saud University. He has done his BGY1 clinical pharmacy at Security Force Hospital program and done his BGY2 in cardiology at Prince Sultan Cardiac Center. Dr. Al-Garni is an American board certified pharmacotherapy specialist and certified cardiology pharmacist. Please welcome and join me warmly, Dr. Faisal Al-Garni.
Assalamu alaikum. I would like to welcome you again to the cardiology session, which is the most awaited session. Today we have 2 distinguished speakers. The first speaker is my colleague, Dr. Sami Al-Salmi, and the second speaker is one of the leaders of cardiology pharmacy, Dr. Abdurrazzaq Al-Jazairi. Today we have 2 interesting topics will be presented. I'm pleased to introduce Dr. Sami Al-Salmi. Dr. Sami is a cardiology clinical pharmacist at King Saud Medical City. Dr. Sami did his BGY1 at King Saud Medical City and his BGY2 at King Abdulaziz Medical City. Today he's going to be talking about an interesting topic, which is short-term versus long-term use of dual antiplatelet in acute coronary syndrome patient post-PCI. Please join me welcoming Dr. Sami.
Assalamu alaikum wa rahmatullahi wa barakatuh. Sa'adallah masaakum bil khair. First of all, before I start my presentation, I would like to thank the Pharmaceutical General Administration for the invitation and great pleasure to be here. Today I will be talking about a short versus long-term use of dual antiplatelets in acute coronary syndrome post-PCI. Attendees at the end of this presentation will be able to understand the importance of dual antiplatelets and describe the different types of stents, highlight the most recent guidelines and recommendations, discuss the recent studies data in regard to short-term versus long-term duration of dual antiplatelet. Platelet inhibition has been the key component in acute and long-term management of acute coronary syndrome, and the recognition of variable effects of aspirin and platelet activation and platelet aggregation led to the pursuit complementary platelet inhibitors, culminating in the now standard DAPT combination aspirin and B2Y12 inhibitors antagonist. Why dual antiplatelet is very important in patients with ACS, whether they are stented or not, as DAPT provided a reduction in recurrent ischemic events, including stent thrombosis. We'll be talking now about the stent types and why the stent types generated this idea of shortening the dual antiplatelets. We have bare metal stent types and drug-eluting stents. That's the one that I will talk about. And what is drug-eluting stent? The stent has a drug that elutes very slowly over time. It works as an anti-proliferative. It's a immunosuppressant to decrease the antimal hyperplasia and reduce the risk of restenosis and stent thrombosis and also less inflammation. As the advancement in stent generation increases, there will be a reduction in adverse events like stent thrombosis and restenosis. Current guidelines and recommendation, American College of Cardiology and Heart Association 2016 update. As usual, in patients with ACS, whether they stented or not, they should be in dual antiplatelet for at least 12 months. How about patients with high risk of bleeding? They stated such patients who are at high risk of bleeding, they can discontinue B2. In the European Society of Cardiology and Guidelines 2020, they stated about shortening the antithrombotic treatment duration in high risk of bleeding as a precise DAPT, which is a score we use for, to stratify the risk of bleeding in patients, or academic research consortium and high risk bleeding criteria. To be discontinued, the B2Y12 inhibitors on the 3rd month should be considered. And they all, in patients with non-STEMI or ACS, they should be on dual antiplatelets for 12 months. Meta-analysis that published in discussing comparing the short-term DAPT versus long-term DAPT on the prognosis of PCI patients. This is the baseline characteristics of the studies included, where they included 11 trials of more than 20,000 patients. Patients were on dual antiplatelet for 3 to 6 months. And also they continued after 3 to 6 months, most of them, they continued in aspirin. And 2 studies only, they continued patients in ticagrelor or clopidogrel. For the outcomes in the major bleeding or any bleeding, there was a superiority for short-term in any bleeding or any major bleeding. For the secondary outcomes, all causes of death, cardiac death, myocardial infarction, different probable fistula, revascularization, stroke, they were all was disease. About 60 20 for the enough So to sum up my presentation, short-term DAPT can be considered in high risk of bleeding patients. Compared with a long-term DAPT, short-term DAPT reduced the bleeding after BCI, and it was non-inferior in the incidence of ischemic stroke, in the incidence of ischemic events. The use of short-term DAPT is still controversial, and further studies are required to decide regarding the optimal duration of DAPT with newer generation stents. That's all for my presentation. Thank you all for listening.
Thank you, Dr. Sami, for your nice presentation. I believe many questions will be asked about this presentation when we come to the discussion. Now let's move to the second topic. I'm pleased to introduce Dr. Abdulrazzaq Al-Jazairi. Dr. Abdulrazzaq is a clinical pharmacy consultant in the field of cardiovascular pharmacotherapy and the director of clinical trials transformation initiatives at King Faisal Specialist Hospital and Research Center. Dr. Abdulrazzaq has more than 30 original research publications and delivered many national and international presentations. Today he's going to be talking about a debatable topic, which is should secondary prophylaxis prescribed for adult with rheumatic heart disease post-valve replacement? This question will be answered by Dr. Abdulrazzaq. Please join me in welcoming Dr. Abdulrazzaq Al-Jazairi.
Assalamu alaikum jami'an. Thank you very much, Dr. Faisal. First, I would like really to thank my colleagues, in my very beloved Ministry of Health, for the very nice invitation and the great event that we have today. The topic that I'm presenting today, it was supposed to be a debatable topic with one of my colleagues from an infectious disease specialty, but I see Dr. Khalid Al-Ju'ali here, so he can debate what we're talking about today. The topic assigned to me, should we really consider antibiotic secondary prophylaxis in patients with rheumatic heart disease post-valve replacement?
It's a very interesting question, at least to me, since I started working in King Faisal as a clinical pharmacist in cardiac surgery. We've been dealing with lots of rheumatic heart disease patients. I can walk into the cardiac surgery ICU and I can tell you which patient without looking at their profile if they are rheumatic heart disease patients and they're coming for a valve replacement or a redo valve replacement. And we always lived with this very controversial question, should we really continue antibiotic prophylaxis for these patients after replacing the valve? For those of you who dealt with surgeons, surgeons are very difficult people to deal with. And the first argument they will tell you, if I change the valve to a mechanical valve, why would you need an antibiotic to help these patients? The valve is already changed. Why do we need to continue antibiotics? Why should we give an intramuscular injection? And most of the patients on warfarin, development of hematoma can be a very bad experience. And the discussion can go on and on. So what I'm going to try to do today is to provide some background on the disease itself, where the guideline stands, and what our real life study showed at King Faisal from data that we reviewed from 1990 until today. It starts in a very simple way, especially in pediatric age, where patients, they develop pharyngitis, most likely due to a streptococcal infection, group A. And the story starts there where about 3 to 4% of these patients, they will develop rheumatic heart disease if they did not get treated on time and treated adequately. This is, by the way, is very true. When you look at the pathophysiology of the disease, there is a similar antigenicity between Streptococcus group A and the native valve, especially the mitral valve. And that's why mitral valve is responsible for 90% of rheumatic heart disease. Many of the patients with rheumatic heart disease, when you ask them what happened, they said, my physician told me the bacteria went down from your throat to your heart, which is not necessarily accurate. It's always they mention this to you. But actually, it is an autoimmune disease. It's a humoral and cellular autoimmune disease due to the mimicry effect of antigenicity between the valve and the streptococcal infection. Once our immune system identified and trying to attack the bacteria, it's going to continue forever attacking the valve because of the similar antigenicity. People, they will say this will be aggravated every time you get pharyngitis or streptococcal infection. So should we give antibiotics for these patients to prevent the aggravation or the exacerbation of rheumatic heart disease for the next time? And that's the discussion that we are talking about today. As you can see, it doesn't show here, but Saudi Arabia is one of the countries that's considered to be endemic when it comes to rheumatic heart disease. If you look at North America in the States, for example, you can barely see rheumatic heart disease, and mainly due to the advanced healthcare system with the primary care, early identification and management of pharyngitis. Very limited data available from in Saudi Arabia, but we did this review recently where we found few studies really, especially in pediatric patients, when they were followed for 5 or 10 years, we found a good percentage of the patients who develop rheumatic heart disease, about 40 to 90%, which is really very much similar to international data. About 50% of the patients who develop acute rheumatic fever, they will develop carditis and valvulitis or valvular heart disease, which is rheumatic heart disease after acute rheumatic fever. The valve that gets involved the most is the mitral valve, as you can see. 90% of the times they develop rheumatic heart disease in the mitral valve that can be extended to aortic valve, to less extent to the pulmonic valve. The way they present again, maybe usually in these screens it doesn't show. But if you look at any echocardiogram, because it is really the standard of diagnosis, you look at the mitral valve initially, you're going to see a thickness in the posterior leaflet that can extend it to other leaflets. This will lead to incompetency in the closure of the mitral valve and causing regurgitation, mitral valve regurgitations. Patients, they present usually with mild to moderate symptoms or asymptomatic. Weakness or apnea. But that can be complicated and develop into heart failure. Atrial arrhythmia, in 60%, they developed atrial fibrillation and pulmonary hypertension. So echo is the mainstay. In the past, we used to rely very much on histocompatibility, but the fact histocompatibility and the presence of what we call Ascoff cells was not really related very well to the development and the diagnosis of rheumatic fever. But it is really the gold standard is echocardiographically. And you have to work very closely with your echocardiographer to confirm the diagnosis so therapy can be tailored to patients. Well, the electrocardiogram doesn't change much, but we look at widening of QRS, which is a reflection of heart failure. In the younger the age, the QRS is going to be shorter. If it's in adult population, which is the interest of this topic, usually it's more than 200 milliseconds. This is an explanation of what I mentioned about valve incompetency. The blue color, it represents a jet of a blood regurgitated back to the ventricle upon closure, which is mean there is a regurgitation and valve involvement, and the posterior leaflet of the mitral valve is getting thickened. Now, really, we are happy, at least last 2 years, the World Heart Federation, they diagnosed, they established the diagnosis through echo, and they have a diagnosis, either it's a definite, borderline, or normal. This is more detailed classification, which is relatively new, at least now. The aggressiveness of the management and monitoring and clinic visits is based on how aggressive or how definite the diagnosis is. So that's just as an introduction, but let us look at the guidelines. What does the guidelines really address to us when it comes to secondary prophylaxis? So the patients, they already have the disease, should they be continued after valve replacement on antibiotics? The recommendation for rheumatic heart disease as a secondary prophylaxis in general, it is for 10 years for adults or until the age of 40. Whichever coming longer should be followed. Long-term follow-up and complication of secondary heart disease are the basic elements of rheumatic fever and rheumatic heart disease. But this recommendation is really more, very much, it's more of an expert opinion rather than a clear evidence for this. And I can tell you at least one of the reasons for this disease is not endemic in the States. You don't have lots of trials, especially randomized controlled trials that can answer such a question. What do we use from an antibiotics point of view? The standard of practice, we use benzathine penicillin, G. Intramuscular, it can be given every 3 weeks or every 4 weeks. If they are high-risk group, as mentioned underneath the table in the legend, it should be given every 3 weeks. If it's not high risk, we give it every month or every 4 weeks. If you cannot give intramuscular injection or patients are not welcoming intramuscular, we can use penicillin V. We use in adults 250 Q12 hours. For individual allergic to penicillin, we use sulfonamide or sulfadiazine. For individual allergic to sulfa, we can use erythromycin, but erythromycin needed to be given Q12. How about azithromycin? Can azithromycin be given? This is an adjudicated recommendation from our guidelines, Saudi guidelines that was endorsed by the Saudi Pediatric Society. We can give azithromycin once daily. Now, the big question, it comes for rheumatic heart disease patients. It's exactly what I mentioned in the previous slides, but our concern, the last last row, which is in severe valvular disease, after valve surgery, the recommendation to give a lifelong antibiotics. And lifelong antibiotic, as you can think, it can be a very challenging for our patients, and the evidence is questionable. So this is the guidelines. It's basically stratified into allergic or not allergic. If they are allergic, you can go to the left side of the slide, as I mentioned in the table. If they are native penicillin allergic, you go to the right side. If they are on warfarin, you avoid injection of intramuscular, and you give oral therapy. And again, the hematoma that come with the intramuscular can be a very bad complication for the patients, and can be very traumatic experience. Especially, you can imagine, we have many patients living in suburbs area. So here is the question is, after valve surgery, the recommendation to go lifelong, but we don't have evidence for this, but it's more of an expert opinion. So what we did, really in our practice, you get all these discussions. We do see lots of patients in the hospital, hospitalized. They're coming for a redo surgery. So they did the first surgery, they're coming to change the valve again. Is it due to the activity of the disease or worsening of the valve? That's a very important question. We have a redo, first, second, third. I have seen fifth redo. But the optimal duration, really, of therapy is become unanswered. So we tried to look at this in our study to investigate the impact of antibiotic use in valve survival in rheumatic heart disease patients post-valve replacement. What we did here, we looked at rheumatic heart disease patients, and we stratified either patients who used secondary antibiotics to compare them to patients who did not use antibiotic, and then we looked at the endpoint of interest. We are focusing on adults. So pediatrics, by the way, is very well established, not for valve replacement for rheumatic heart disease. They have more frequent pharyngitis that might be contributed to this, but we do have data. Very nice study published last year in New England Journal of Medicine. Non-valve patients in pediatrics, it was 2 years follow-up study, showed clearly there is a benefit of continuation of secondary antibiotic prophylaxis for pediatric patients with rheumatic heart disease. So we wanted to look, the guidelines is there, the institutional guidelines is there, international guidelines are there, but what's the real antibiotic use prophylaxis, and how does that relate to clinical outcomes? In a simple term, really, we found the adherence to the guidelines about 18%. So in every 10 patients, 2 of them, they were on antibiotics after valve replacement. But a good percentage of patients who do qualify to be on antibiotics, they are not on antibiotics. The most widely prescribed medication was penicillin V, and followed by benzathine penicillin. Very much the same percentages. Main reason because they had more mechanical valve. They are on warfarin, so they will not get an intramuscular injection. When we looked at the whole cohort, it was the average, or the median was 40 for the whole cohort. For patients who received prophylaxis antibiotic, they were significantly younger than non-prophylactic. Gender distribution was the same. Left ventricular ejection fraction less than 50. It was higher with patients who were not they were in mitral, and they received mechanical valve, as you can see, in non-antibiotic use. Mitral biological was more in the prophylaxis. As you can see, it's reversed compared to mechanical. That makes sense. Aortic mechanical was the next valve. Also, it was almost the same, although relatively it was higher in the prophylaxis group. This is a very interesting, in my opinion, slide. So this is a Kaplan-Meier curve where we looked at survival in general over the years of follow-up. We included patients from 1990 until 2014 to allow more years for follow-up. The data was truncated over 12 years as the majority of patients were followed for that period of time. And you can look at the attrition rate where we started with about 1,200 patients. That was reduced to about 1,100 patients. Majority of patients were not on a prophylaxis, about 884, and on antibiotic prophylaxis were 200 patients. On this figure, you can see patients who received antibiotic prophylaxis. They did much better with regard to overall survival. However, we mentioned the variability of the confounders at baseline, and when we corrected for this with propensity score matching, really that difference disappeared. So age was a main factor with regard age, atrial fibrillation, and others. A type of valve was main prior. So this difference really disappeared after propensity matching score analysis. It's interesting also here with regard to we looked at either death or reoperation. Also, there was no difference when we looked at propensity matching score. Same thing, we looked at death, reoperation, or valvular hospitalization. Also, there was no difference before and after propensity matching. So our data really did not show a difference in a big clinical outcomes between prophylaxis and non-prophylaxis, but I want to remind us really talking about 40. So they are young, middle-age group with valve replacement. Lots of unanswered questions, including genetics, for these patients. Why do their valve doesn't survive that long, but it's worth an exploratory study? If you are interested to read more, our study was published last week, so you can get more details. In conclusion, the current guidelines recommended lifelong antibiotic use for adults, but this was not really based on evidence. It's rather on expert opinion. The recommendation might need to be revisited as more data become available, despite the presence of the guideline.
I didn't have a question, but yeah, I think it's. I agree with you. The recommendations are based mostly on expert opinion, and we encourage everyone to publish similar studies so we can understand more the whether we need this or not about the duration. And you know, I'm glad you did the propensity score matching. This was very important because, as you said, because of the differences between the two groups, particularly the age. And maybe another question is not sample size. Maybe they would find a difference, or what do you think?
Thank you, Dr. Khalid. Now, the sample size to find rheumatic heart disease patients post-valve replacement, you will not find them in thousands. Usually, these are very limited number of patients, and our Apollo registry going back to 1990, still you come up with 1,200 patients or so. Maybe if it's done definitely on a national level and maybe international areas, countries endemic like India, Far Eastern, we will learn more. But it can be definitely a question of a sample size. But again, sample size, what effect size are you looking for as a difference at the very beginning? When you look at the trials, even the newest trials published, usually it's around 100, 200 maximum. But for valve replacement, rheumatic heart disease, looking at redo, maybe it might not be easy to find. I think the big question is really what was in our practitioners' mind when they prescribe one patient antibiotic, the other do not. And that's most of the discussion in the manuscript, and many of the reviewers who reviewed the manuscript, that's the main question. I believe it's becoming a discretion of the treating physician, whoever working in the valve clinic, and their belief with the guidelines. But it can be definitely a question of sample size. To get an answer, we need a long-term randomized double-blind placebo control. And I hope, I hope before my retirement I can do such a study.
Thank you, Dr. Khalid, and thank you, Dr. Abdulrazzaq. Dr. Abdulrazzaq, I would like to ask, are there still some scenarios that we still need to use long-term prophylaxis? For example, for patients who are considered having high risk for infection?
I think the big message here, I will still use a long-term prophylaxis for high-risk patients, as it was stated in the guidelines, as a high risk. I cannot be very definite about the answer, but if I have a patient with an age of 40 and above, I'm not pushing very hard for antibiotic prophylaxis, to tell you the truth. If I'm in the valve clinic and I see a patient who is 20, 25, 30, and coming for a redo, these patients I would recommend giving antibiotics. For patients who are really in 40s and above, I will not push for it first for multi-clinical morbidities that they do have, and pushing for an intramuscular or continuation of antibiotics. It is really questioning in absence of enough evidence. I will not be very pushy for that age group and low risk.
Okay, thank you, Dr. Abdulrazzaq. Now I have a question for Dr. Sami. Dr. Sami, with all the evidences that you have mentioned in your presentation, is there still a place for DAPT score to be used to guide the duration of the dual antiplatelet?
For patients who are at high risk of thrombosis and they have a low risk of bleeding. However, what I mentioned here in the more focused on new scores, precise scores, which if it was like more than 25 or more, it's very high risk of complication from the bleeding, or also the academic research Constrom criteria. If they are met, this patient is a very high risk of bleeding. However, the risk of stented thrombosis is still there, but it was reduced with the newer generation. Also, the reason why we use also the DAPT score, we still can use the DAPT score, is that the risk of stented thrombosis still
that is and stent thrombosis. Would you like to add any comment?
I have a common question for Dr. Salmi. The most common question about dual antiplatelets, of course, when do we stop? And when we stop, which medication will you drop and which condition?
This is actually the most P2Y12 inhibitor bleeding, and it did not affect the ischemic the ischemic events comparing to aspirin, which was not significant.
And again, it is very interesting because public always they ask you, and many physicians they are hesitant to stop the either aspirin or Plavix, but there might be some compelling indication that will say one over the other. Aspirin is considered a background antiplatelet for any additional antiplatelet, although it is really Plavix is non-superior to aspirin. So the decision, it can be in the presence maybe of certain compelling indications and preference, but from evidence point of view, really it doesn't make a difference as far as you fulfilled the duration pre-decided based on the risk score that you adapt risk score.
Okay, thank you, Dr. Abdulrazak. I think we can take one more question. Go ahead.
السلام عليكم. شكرا دكتور عبد الرزاق. شكرا دكتور سامي. Nice presentation and informative. My question to Dr. Abdul Razak about the study. We can add other parameters in the study, like the quality of the life, efficacy, activity. We can look for the other parameter, like also the lab result for the patient, as white blood cells or other parameter in. Thank you.
Disease here. So when we talk about lifelong antibiotic use, especially we're talking about 50% of the patients, 60% they will be on anticoagulant, so they will be in oral, and the other 40 they're going to be on intramuscular. We need to look at, we need to do really a cost-utility analysis to see if this approach is really cost-worthy or not. We did not do any cost-effectiveness or cost-utility. In my opinion, it is very, very important to look at such a thing. This is more an efficacy of a clinical outcome point of view, not to mention the limitation of the study being a retrospective cohort study. And no matter what you do with propensity scoring, trying to adjust for confounders, it has its own limitations. The ideal answer is coming with a prospective randomized controlled trial. But I will say, definitely it's worth looking at doing cost-utility analysis on this study in particular, and reflecting back on our population and disease burden in Saudi Arabia.
Thank you.
We are almost out of time. Thank you, Dr. Abdulrazak, for your nice and informative presentation, and thank you, Dr. Sami, for your nice presentation. By this, we can conclude our session. Thank you.
I would like to take a moment to express our greatest gratitude and thanks to our speakers and moderator. I wish to invite Dr. Fatma Dlegan to the stage. Dr. Faisal Al-Garni. دكتور سامي. دكتور عبد الرزاق الجزائري. We would like to continue to our last topic with outstanding moderator, Dr. Mohammed Al-Nahid. Dr. Mohammed Al-Nahid is a Director, Pharmaceutical Division and Clinical Pharmacy Consultant at King Faisal Specialties. He graduated from King Saud University with bachelor degree and received PharmD degree from St. John Fisher College. He completed BGY1 pharmacy residency training at the University of Arizona and BGY2 pharmacy residency at oncology at the University of Chicago.
Thank you very much for the introduction. I'd like also to thank the organizing committee for creating this event and inviting me. I also would like to thank you all for staying late because I know it's been a long day. It is my pleasure to moderate the next session focusing on hematology oncology. In this session, we have two presentations delivered by two distinguished speakers, followed by a Q&A session. Our next speaker is Dr. Majid al-Shamrani, who will be talking about immune checkpoint inhibitors, a decade of clinical experience in oncology. Dr. al-Shamrani graduated from the Faculty of Pharmacy at King Abdulaziz University in Jeddah with a PharmD degree in 2008. Dr. al-Shamrani then completed his residency training, general residency and hematology oncology residency, both at the same institution. He obtained his American Board certification in pharmacotherapy and certification in oncology in 2014. He is actively numerous national and international conference speaker and moderator. He is currently working as a consultant clinical pharmacist in hematology oncology over at Princess Noura Oncology Center at King Abdulaziz Medical City in Jeddah. He is currently appointed as Oncology Pharmacy Residency Program Director, and he is also the founder member of the Saudi Oncology Pharmacy Assembly, or SOPA. He's also a board member in the Saudi Oncology Society. Dr. al-Shamrani appointed as a member in the Clinical Pharmacy Scientific Council under umbrella of the Saudi Commission for Health Specialists. Please join me, welcome Dr. al-Shamrani.
بسم الله الرحمن الرحيم. أسعد الله مساءكم جميعا بكل خير. Thanks Dr. Nahid for your kind introduction. Special thanks to our colleagues in the scientific and organizing committee for their kind invitation and organizing this high caliber conference. Over the next 20 minutes or so, I'll be excited to share with you some lessons that we learned after using immune checkpoint inhibitors in treating cancer patients. As all we know that cancer is considered the second leading cause of death, and this was based on the recent reports that we get from the American Cancer Society statistics and figures. They mentioned in their report that there was a trend toward survival improvement in the past couple of years, and this was mainly due to two main reasons. The first reason for improvement in the survival was the recent advancement in diagnostic procedures as well as the early detections of many cancer types. And the second important reason, which is really important to us as a pharmacist, is the introduction of highly effective medications, more specifically immune checkpoint inhibitors. Immune checkpoint inhibitors or immuno-oncology now is standard of care in many cancer types, and it caused a paradigm shift in cancer management. So immune checkpoint inhibitors is considered the fifth pillar alongside with surgery, radiotherapy, and other systemic treatment. Well, so the story of immune checkpoint inhibitors started with the discovery of checkpoint pathways by two scientists, one from United States and the second a researcher from Japan, Prof. James Allison and Prof. Tasuku Honju. They were able to discover the checkpoint pathways. So they discovered this back in early 2000s. After their great discoveries, the pharmaceutical companies were able to develop a molecule called immune checkpoint inhibitors. So after this great achievement, Nobel Committee decided to award them with Nobel Prizes in 2018. So those two scientists were jointly awarded with Nobel Prize in 2018, and the reason for this award was the great achievement and the astonishing results after the introduction of immune checkpoint inhibitors into the clinical practice. This is my disclosure, and I hope at the end of my presentation the audience will be able to understand the concept of immuno-oncology and the role of immuno-oncology medications in cancer management. I'll briefly discuss the evidence and the place of therapy of
immune checkpoint inhibitors in 3 main cancer types. And the second part of my presentation will be focusing on the immune-mediated side effects of these agents. In the beginning, let's agree that immunotherapy and immune system stimulation is not a new approach. Actually, over a century, the scientists were trying to stimulate the immune system to attack the malignant cells. And this approach, the old approach, rarely resulted in overall response rates, and it was associated with severe toxicities and mortality with the old immunotherapy medications. More recently, and after the great discovery of Prof. James Allison and Tasuku Honjo, we have better outcomes, great outcomes with the new medications. As you can see in this timeline, this is the FDA approval timeline for immune checkpoint inhibitors. The approval was started back in 2011 with the approval of ipilimumab, which is known as CTLA-4 inhibitor. This medication was approved mainly in melanoma in 2011, followed by, I can see like dozens of approvals for other immune checkpoint inhibitors. Now we are talking about almost 9 immune checkpoint inhibitors licensed to be used in treating more than 20 cancer types. Pembrolizumab is among the top list. It's considered number 1 in terms of FDA approvals, followed by nivolumab and ipilimumab. Durvalumab, pevilumab, atezolizumab, these medications were introduced later after the initial phase of approval of immune checkpoint inhibitors. And more recently, we received 3 approvals for cemiplimab and tremelimumab and dostarlimab, several types of cancer. The immune checkpoint inhibitors, all of them are administered by IV infusion. Patients can be either admitted or receive these medications in outpatients. These agents can be given as monotherapy or can be combined with the targeted therapies or chemotherapy in few indications. All of them have great outcomes in both metastatic setting and early diseases. And the infusion time for these agents is from 30 to 60 to 90 minutes. If the patient develops any kind of allergic reactions or infusion-related reactions, we should support our patients with pre-medications and extend the infusion of these agents. Now I will shift my talk to the place of therapy of these agents. And before that, I would like to tell you that immune checkpoint inhibitors resulted in great outcomes. It led to a significant survival improvement. Now we are talking about more than 3 years survival with some of the immune checkpoint inhibitors. It resulted in durable responses even if the patients discontinue these medications due to either side effects or intolerability to these agents. It has favorable side effects if we compare it with the conventional chemotherapy. It is associated with less grade 3 and 4 toxicities. However, these medications have something called immune-mediated side effects. Immune-mediated side effects can be occurred in any phase of the treatment with the affecting any organ of the bodies, and it can lead to discontinuation and premature discontinuation of immune checkpoint inhibitors. Immune checkpoint inhibitors or immunotherapies were studied extensively in non-small cell lung cancer and small cell lung cancer. It can be used in both new or early disease, and it can be used for advanced or metastatic disease. As you can see from the forest plot, the number of clinical trials conducted in lung cancer. Now we are talking about 3 years survival in some of the non-small cell lung cancer patients. The immune checkpoint inhibitors is mainly used in first-line non-small cell lung cancer in those patients who have PDL expression, especially if they have more than 50% immunohistochemistry result of the PDL1 expression. When we talk about breast cancer, not all patients with breast cancer will benefit from immune checkpoint inhibitors. We use it in subset
group of patients known as triple-negative breast cancer. In triple-negative breast cancer, because of their nature of the disease, immune checkpoint inhibitors play a major role in both neoadjuvant setting as well as in the metastatic setting. Pembrolizumab and atezolizumab were granted the FDA approval to be used in metastatic setting initially. Atezolizumab was the first immune checkpoint showed a survival advantage in an Impassion 130 trial. In the another confirmatory trial, atezolizumab was studied with paclitaxel. Unfortunately, it was a negative trial, and the company decided to voluntarily withdraw the application or the approval from the FDA. So now we are talking about only one agent. Pembrolizumab is approved for triple-negative breast cancer based on Keynote 522 trial and neoadjuvant setting. Pembrolizumab resulted in a significant improvement in complete pathological response. This is in early stage breast cancer, triple-negative breast cancer. And the other indication is pembrolizumab in metastatic setting. It resulted also in a significant improvement in overall survival. In colorectal cancer, immune checkpoint inhibitors played a major role, especially in patients with high microsatellite instability. MSI high patients is usually a candidate for immune checkpoint inhibitors, especially if they have advanced disease. In early colorectal cancer, a few months ago, we had great outcomes with the new immune checkpoint inhibitors, which was dostarlimab. Dostarlimab resulted in 100% complete clinical response, but this was based on phase 2 trial, and they included only 14 patients in neoadjuvant settings, and those 14 patients did not go for surgery, so they received only 6 cycles of dostarlimab, and this was resulted in, again, 100% clinical response rate. When it comes to the biomarkers, biomarkers are linked directly to the response. We commonly test for BDL1 for the efficacy of pembrolizumab and nivolumab and all other in certain indications. The second biomarker is known as tumor mutation burden. We usually measure this using we test the number of mutation per megabase DNA. So both BDL1 and TMP, if patients has high result of these two biomarkers, we expect better response rate compared to BDL negative or low TMP patients. The third biomarker is known as microsatellite instability, which simply means that patients will have more mutations and will have damaged DNA, and the patient will not be able, or malignant cells will not be able to correct, so they will have deficiency in the repair mechanism, or known as deficient MMR patients. In those group of patients, they usually respond to the immune checkpoint inhibitors. For example, when we talk about cancer in general, if the patient, any types of cancer, if they have high MSI, they will be a candidate for pembrolizumab, for instance. When we use immune checkpoint inhibitors, we were talking about a great efficacy. However, the use of immune checkpoint inhibitors is associated with risk of immune-mediated side effects. After the introduction of these agents, the international societies were excited to see the safety profile of these agents. These agents is associated with unique toxicities known as immune-mediated. So now we are talking about 3 main guidelines specifically written for management of immune-mediated side effects. We use ESMO guidelines, we use ASCO, and the third one is which is NCCN guidelines. Personally, I prefer to use NCCN guidelines because they have more updates. The updates in these guidelines is more frequent compared to the ASCO or ESMO guideline. This figure is just to show you the risk of immune-mediated side effects. These agents can cause any kind of immune-mediated side effects. It can cause colitis, hepatitis, transaminitis, hypothyroidism or hyperthyroidism, causing thyroiditis and any kind of itis. So physicians need to be vigilant, especially in the initial phase of the treatment. When we compare the group of immune checkpoint inhibitors, CETLA4 is considered or it can have the highest prevalence of immune-mediated side effects compared to BDL1 or BD1 inhibitors. And the most common toxicities with these agents, among the top is the dermatological toxicities. We see many patients with skin rash, grade 3 or grade 4 toxicities. Transaminitis and thyroiditis or thyroid disorders is also common, so you need to monitor your patients very closely. Pneumonitis is very rare, however, it's very severe toxicity. So it's really important to anticipate these side effects. These side effects generally occur within the first phase of the treatment, 3 months after initiation of immune checkpoint inhibitors. And in case of immune-mediated side effects development, physician needs to grade these toxicities using CTCAE criteria. We usually grade the toxicities. If the patient has mild toxicities, we usually continue the treatment and offer them steroid. Steroid is the mainstay treatment for all kind of immune checkpoint inhibitors. But if the patients develop grade 3 or 4 toxicities, we need to stop the treatment permanently. And this is a recommendation by the 3 guidelines I mentioned earlier. Tissue biopsy is needed for severe toxicities, especially the skin toxicities. We need to inform our patients about the immune-mediated risk, side effects risk. So the patients need to be very cooperative, needs to report any unusual side effects after the initiation of immunotherapies. Again, the mainstay treatment of immune checkpoint inhibitors is steroid. Steroid is indicated for all grades of immune checkpoint inhibitors. Toxicity except 2 side effects, which are the thyroid disorder. We usually, if the patient develop hypothyroidism, we usually support them with levothyroxine. And if the patients develop DKA or diabetic ketoacidosis, we should not use a steroid, and we usually offer them the protocol used for DKA management. The other supportive care for steroids, as you know, we use it for long period of time, so we expect a risk of infections, so patients need to be supported with BJP prophylaxis, PPI, antifungals, vitamin D, plus calcium to prevent osteoporosis with prolonged use of steroid. The most important message that we usually discuss and deliver to our physicians is the tapering. We should not stop steroid if in case of immune-mediated side effects, even if the patient recovered from these side effects. We need to be patient. Patients usually need at least 4 weeks of steroids with longer tapering. Here I'm sharing with you 2 papers that we published, National Guard, one from National Guard in Riyadh and the second paper from our center in Jeddah. We studied the safety profile of immune checkpoint inhibitors. Both studies reported a high number of immune-mediated side effects, especially in National Guard Riyadh experience. They are reported more than 35% of immune-mediated side effects in their patients. In our center, we reported around 10%, and the reason for that because of the sample size and the immune checkpoint inhibitors that they included in here in Riyadh study. The majority of patients were nivolumab patients, and they included only 6 patients in pembrolizumab. In our study, majority of patients were lung cancer patients, and majority of them received pembrolizumab, which is the standard of care in many non-small cell lung cancer patients these days. Beside that, we are currently doing studies to compare or to assess the effectiveness of pembrolizumab and other immune checkpoint inhibitors and non-small cell lung cancer, and we expect the result to be published soon. So, to conclude this talk, immune checkpoint inhibitors has changed the landscape of cancer treatment in different types of cancer. These agents is associated with great outcomes. However, it have a dark side, which is the immune-mediated side effects. Physicians, patients, pharmacists, all healthcare providers need to be vigilant whenever prescribe the immune checkpoint inhibitors. This steroid is the only intervention in majority of cases. And the last important point is the use or the role of biomarkers is really important. Now we are talking about 3 biomarkers. We expect more biomarkers to have better understanding about both the efficacy and the response of these agents in solid tumor and in other diseases. With this slide, I conclude my presentation today, and thank you so much for your attention.
Thank you very much, Dr. Majid, for the wonderful presentation. We're going to leave our questions till the Q&A session. Our next speaker is Dr. Taha Al-Qahtani, who will be talking about CRISPR-Cas9 technology and its implication in AML therapy. Dr. Taha Al-Qahtani received his Bachelor of Pharmacy from the College of Pharmacy at King Khalid University in 2009. After graduation, he occupied the teaching assistant position at the Pharmacology and Toxicology Department until obtaining his master's degree in pharmacology in 2015 from the College of Pharmacy at Massachusetts College of Pharmacy and Health Sciences University. He was appointed as the head of the Pharmacology and Toxicology Department and Vice Dean between 2015 and 2017. He obtained his PhD in molecular pharmacology in 2011 from the Department of Pharmacology and Therapeutics over at the University of Liverpool. Dr. Taha currently holds an assistant professor position at the Department of Pharmacology and Toxicology since July 2021. He continued his active involvement in the college committees until he was appointed as a vice dean for the academic affairs and development in 2022. Dr. Al-Qahtani published many scientific articles in peer-reviewed journals. His research interest includes molecular pharmacology, drug discovery, and gene editing. Dr. Qahtani, the stage is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the introduction. It's an honor to be here today. And I would like to start my talk by thanking the IHOP conference organizing committee for giving this opportunity and for their kind invitation to talk about science, because science and clinical practice cannot be detached from each other. And that's why we always try to put an effort to bring these two things closer to each other whenever we talk about any pharmaceutical science. It's been a great time so far in the conference, and I'm sure this will continue to the last moment, inshallah. So I really have the pleasure of sharing with you some incredibly exciting science, where we're kind of at the moment right now in the biology that is unprecedented in sense of having all of these molecular biotechnology techniques coming together. And one of them is what I'm going to talk about today, which is called CRISPR-Cas9 technology, that gives the opportunities to manipulate the DNA in ways that will be useful clinically in near future. So the main objective of my talk is to explain the potential of CRISPR-Cas9 gene editing tools in terms of exploring the way that we can understand the mechanism of resistance that usually emerge during cancer treatment, and also to identify how we can use this gene editing tool to find a new therapeutic avenue that can extend our ability to treat cancer in general. So by the end of my talk, if someone never heard about CRISPR-Cas9 technology, and then we were able to touch their curiosity to read more and to appreciate this technology, that's the main outcome and the ultimate goal of my talk. So the genome editing tools development has opened our ability to study the advancement of this technology and to study the genome sequence basically in all eukaryotic cells. This has extended our ability to elucidate the contribution of genetics in terms of promoting an accurate either animal or cellular model of different pathological disease. And also in the way that how we can use this technology to target the DNA at a very, very precise level. So the genome editing tools, or what we call endonucleases, include but not limited to zinc finger nuclease, TALEN, and CRISPR-Cas9 technology. And all of this technology basically has redefined the boundaries of molecular biology research. So the fundamental element of these tools is basically having this specific DNA sequence, which is pre-designed from the scientist that can target its complementary sequence in any place within the human genome. And this specific DNA sequence usually is linked to what we call endonucleases, which is the protein that can bind to the DNA, and upon binding is introduced the double-strand break. So basically it cuts the DNA within the human genome. The CRISPR itself has several advantages over ZFN technique or TALEN because it's efficient, simple, and precise. And nowadays, many scientists view the CRISPR-Cas9 technology as one of the greatest biotechnology in the last century. So, so what is a CRISPR? Just in a very basic way. So in 2020, Nobel Prize in Chemistry was awarded to two scientists, Dr. Jennifer Doudna, American scientist from University of California, Berkeley, and Dr. Emmanuel Charpentier, a French microbiologist, for their discovery of CRISPR-Cas9 technology and how they were able to employ this technology to be used in human genome editing. But let's go back to the CRISPR itself. What is a CRISPR? So CRISPR is basically a natural, adaptive, prokaryotic immune system. So this is how the bacteria can defend itself when the virus attacks the bacteria. So it's a natural thing in the nature. So basically what happens is upon binding of the virus to the bacteria, the virus will release its viral DNA content, and this will be incorporated in what we call CRISPR array. So the CRISPR array is the first line. For example, the blue one, it's the first virus DNA content. And then we have this fixed palindromic repeats, which is in the black color, and then we have another from a previous or past infection of other virus. So this is the name. CRISPR comes from cluster regularly interspaced short palindromic repeats. So what happens next? This CRISPR array will be transcribed to what we call pre-CRISPR RNA, and then another two compounds one called Cas9 and the other one is called tracer RNA, will be merged with this CRISPR RNA to make this final complex. So if this bacteria exposed to this virus again in future, it's like a memory compound that will go and tackle this viral DNA and start to wind the DNA component of the virus and then cut this infection. So the reinfection, it's basically impossible. So what these two scientists done is they start to think how we can use this natural defense mechanism and to employ this technology for human genome editing. So this is a slide just to show you how Dr. Jennifer and Dr. Emmanuel start to think about this technique. So we have this CRISPR-Cas9 molecule. It's basically the same as the one in the bacteria with only one modification, and that modification leads to the Nobel Prize in 2020. So we have the tracer RNA in red color, and then they add this linker loop just to link the tracer RNA with the CRISPR RNA. And then we have the same Cas9. They give the name single guide RNA or sgRNA for this DNA sequence. So all what we have to do to target any DNA sequence within the human genome is to design this single guide RNA. It's almost 20 nucleotides, from 20 to 26 nucleotides. So if you know your target, for example, any gene in terms of cancer treatment, right? So you go and check the exon, the genome, you design your single guide RNA to be complementary when it comes to binding, and then you add this CRISPR. It will go directly at a very precise level, bind to this DNA, and then the Cas9 molecule will induce the cleavage. So this is basically the general theme and the idea of CRISPR-Cas9 technology. So the CRISPR timeline, so the origin of CRISPR back to 1980s. And to be more specific, in 1987, a Japanese scientist called Astu Nakata from University of Osaka and his team, they report the CRISPR as a name for the first time. So they only discovered there is something called CRISPR. But it wasn't until 2007 when a yogurt company identified it as an unexpected bacterial and natural mechanism to fight virus. And then in 2012, scientists, Dr. Jennifer and Dr. Emmanuel, they start to combine the CRISPR component because they were different entity in the bacteria, but they start to merge the CRISPR molecule with the Cas9 molecule to end up with this final complex. After 2012, there was an explosion in terms of research, around 600 papers talking about CRISPR-Cas9 only for 2 years, from 2012 to 2014. And then in 2015, Chinese scientists, they published for the first time using of CRISPR-Cas9 gene editing in non-viable human embryo to treat beta thalassemia. And in 2015 again, the journal Science voted CRISPR as the breakthrough of the year. So what is the ideal example so far for CRISPR? What we are heading to and what right now is going on about the CRISPR-Cas9 technology? The best example is the FDA actually approved for the first time in 2019 to use the CRISPR to correct the genetic mutation causing sickle cell disease. So there were 3 groups of scientists from 3 different universities, UCLA, Berkeley, and UCF in United States. They start to think how we can use and utilize this technology in order to treat patients with sickle cell disease. So the sickle disease, the main cause of sickle disease is the gene mutation in beta-globin gene. So they have this normal allele or normal gene with a certain sequence. However, the mutation that caused the red blood cells to be changed from the regular shape to this sickle shape is these mutations. So for 6 years, after they got an idea in 2012 or 13, after done all in vivo, in vitro experiments in the lab, they start and they apply for the FDA to start the phase 1 clinical trial using the CRISPR-Cas9 technology to only change this very precise nucleotide that caused this mutation. And I just yesterday go back to this clinical trial to see what's going on. So they finished the phase 1 and they will start the phase 2 in few weeks, and they expected to have the final result by the end of 2025. 75 patients have cured completely from sickle cell disease by only 1 single dose of CRISPR-Cas9. You can imagine what would happen in future, inshallah, if you use this technology to treat any genetic disease, including cancer. So my example today, and the topic that I will give some example about the useful of CRISPR-Cas9 technology is oriented to acute myeloid leukemia. So it's hematological malignancy resulting in uncontrolled clonal proliferation of abnormal or undifferentiated myeloid blast cells in bone marrow and also in blood. It's a heterogeneous disease, so there are a bunch of different or many genes that get dysregulated during the progression of acute myeloid leukemia. So basically we have different targeted therapy to try to treat AML based on these genes. It's the most common acute leukemia in adults. The 5-year survival rate is 28%. The standard chemotherapy is 7.3 regime. So how we can use CRISPR-Cas9 to understand the AML and to start to think about using this technology in future as a therapeutic tool. This is just one example. So this paper published recently in Cell Stem Cell with an impact factor of 24. So the CRISPR gene editing used to build the first model of AML progression. And what the scientists done here in this paper, basically, they used introduced pluripotent stem cells to build up a model of the AML progression from scratch. So they have this green circle, the parental iPSC cells, and then they start to introduce a sequential genetic mutations that usually happen in the AML by using CRISPR-Cas9 technology. So they introduce first this mutation, ASXL1, and then the next mutation is SF2, and then the NRAS. We know all about the NRAS and how it is implicated in the progression of AML and many other cancers. So by doing this, they were able to tackle the progression of acute myeloid leukemia from a parental cell, only single one, single healthy cell, all the way to the last stage of these diseases. And then they start to read and to map all the genomic sequence or clonal changes among their animal or human cell lines. They found that, for example, there are many inflammatory mediators found to be dysregulated during very early stage of AML progression. And then when they use different anti-inflammatory molecules, they were able to stop the clonal formation and the progression of the disease. This is just an example. Like if you want to study any disease, any cancer, for example, you can simply have the pluripotent stem cell and then introduce the mutation you think is very important, and then you can start to tackle what's going on and how to treat this disease. Another example is this work being published in Nature with an impact factor of 49. So they used ex vivo CRISPR screen. They were able to target around 18,000 genes at once. So they have this library of different CRISPR-Cas9, and then they were able to target 18,000 genes to figure out which one is very important and has a vital role to introduce the cancer. And they end up with 46 genes they thought it's very important, and then they found that the inhibition of a protein called METL3 kill the leukemic cells in animal or even in human cells. And what's interesting is that the METL3, they only found it is play a role in leukemic cells, but not in healthy cells. So if someone from now try to develop a molecule to target this protein, it can be very safe because it's only work in the leukemic cells, but not in healthy cells. Third example, in this paper, on this research, scientists try to understand the resistance mechanism, because one of the main issues in cancer treatment in general and in AML specifically is to emerge the resistance mechanism whenever we use targeted therapy. You use quizartinib, you use midostaurin, you use sorafenib for a certain time, and the patient will come back again with a full resistance to this drug. And then you start to think about use a combination of MYC/ERK, AKT inhibitors with these inhibitors. But it will be very interesting if you go back and step back again and try to understand this using our hands-on technology. And then we can think about this initially, like if someone used sorafenib for a certain time, or the ACC20, which is a quizartinib, this is another name. So it's a quizartinib, it's a FLT3 specific inhibitor. And then we understand the molecular biology of this resistance mechanism, so we can easily find the plan B for those set of patients. So what they have done, very simple way, they have this called MV411 cells. So it's a human cells, mimic the AML cells, can be used in the lab. It has a FLT3 ITD mutations, one of the most common genetic alteration happen in AML patients. And then they introduce this CRISPR-Cas9 library, the knockout proteins. And then they treat the cell for 14 days with quizartinib or with the control, the DMSO. They extract the genomic DNA from this cell line, and then they send it and do the RNA-seq analysis. So they study the RNA or DNA at a very precise level. They end up with this idea. They found that there are two molecules, the GSK3 and SPRY3. The reduction of these two molecules is the main reason to develop the quizartinib resistance in acute myeloid leukemia patients. And by doing this, they start to think, okay, if we do a co-treatment or a combination of AC220, the quizartinib, plus another drugs that inhibit the reduction of these two molecules, then we will end up with a very efficient treatment plan for those patients. The last example of acute myeloid leukemia identifying resistance mechanism is this paper. It's been published in Hematologica journal. So what the scientists done here again is similar like the previous slide. They have this CRISPR, the single guide RNA library. They introduce these CRISPR-Cas9 to a cell called MOM13. This cell line has heterogeneous mutations, so it has the FLT3 ITD mutations and the FLT3 wild type protein. And then they start to treat the cell with sorafenib. And then again, they extract the genomic DNA, and then they do the deep analysis. And again, they found all of these protein with the red circle color is being dysregulated in the mTOR MAP kinase pathway, BI3K-AKT pathways, which is the main pathways that has an implication in development of survival and proliferation of acute myeloid leukemia patients. So again, if we can target these molecules in future, then we will be able to decrease the resistance that usually emerge against sorafenib. So I will give you just in next few slides an example of a real-life experiment, the work we have done in our lab. Is try to understand the resistance mechanism to quizartinib. So we all know that the FLT3 is one of the main receptors found to be dysregulated in acute myeloid leukemia patients. This protein, or the expression of this protein, is very restricted to early progenitor cells. However, in AML patients, this protein is found to be overexpressed in almost 90% of AML patients. Not only the overexpression, but actually it's found to be mutated in almost 1/3 of the patients. So on the right side, this is a signaling pathway happening within the cell in AML patients. The one with the blue color is the normal pathway. So this is the FLT3 receptor. There is a ligand called FLT3 ligand. Upon binding to this receptor, usually there are different signaling pathways being activated. But what happens in AML patients is this protein is always active. So it has this activation for the two main pathways, the RAS and PI3K, but there is also the third one, which is called activated in acute myeloid leukemia patients. So we start to think, okay, let's try to CRISPR or to knock out the STAT5 protein and to see if we can change this AML status in the patients. So why we choose STAT5? Because again, this activation of STAT5, it's only occur in AML patients, not in normal people. And the direct inhibition of STAT5 is a bit challenging because of its size. And also there is two different isoforms, STAT5A and STAT5B. So I'm not going to explain this, but just to give you an overview, what is a CRISPR and how you can do it within the lab. So in future, if you end up with a CRISPR-Cas9 medication, hopefully, inshallah, it will be approved soon for many diseases, then you can figure out how people done this within the lab. So you have your cell line, which is AML cell line, the MP411 cell lines. You add the Cas9 protein, you do what we call the selection, and then you just pick up the clone that get this Cas9 protein, and then you do the purification and do the functional assay. You start to do the in vivo and in vitro experiment, and then if you end up with a solid result, you can apply to move for clinical trials. So when we talk about CRISPR, we talk about changing the sequence at a very precise level. It's just fascinating. You want to delete 10 nucleotides, you will end up with deletion of 10 nucleotides of your target DNA. This is just an example of what we have done in our lab. So this is the STAT5 sequence. We have GTCA, blah, blah, blah. And then we design 3 different single guide RNA or CRISPR-Cas9 molecule. So we know exactly that if we use the STAT5 guide 1, like the CRISPR one, with guide 2, we will cut exactly 104 base pair. However, if we use guide 1 with the guide 3, we will cut 153 base pair. This is what we designed initially, okay? So we designed our CRISPR-Cas9 with a certain sequence to be complementary to our target STAT5 protein. You can see the Sanger sequence, the one on the right side. When we do the experiment, we add the CRISPR-Cas9 with all of these. There is multi-steps to reach this point, and then we send our DNA for sequencing, we end up exactly with this deletion. So as a scientist, you can delete this particular segment of your DNA. And we know that if we cut this DNA, we won't have STAT5 anymore in AML patients. And you can imagine this, you can do it, for example, in any cancer type. Let's say patients with AML, they have, as I said, the FLT3 ITD mutations. This mutation is, for example, for 20 base pair. You can even do and rewrite and change this from a mutated DNA sequence to a wild type, a normal DNA sequence. So you will cure the disease at only once shot. So this is just to show you an example of what we're doing right now. And then in future, inshallah, we will continue. We want to establish this. We want to study further and further using different models before, inshallah, going for the next step. So what is the future of Cas9? As usually they said, a picture is worth thousands of words, right? So this is the number of publication for CRISPR-Cas9 technology since the moment of its discovery. And you can imagine that from 2012, as I told you, to, for example, 2018, we have around 4,000 papers, okay, for CRISPR-Cas9 technology. This is the future of the therapeutic treatment of any disease that caused any genetic mutation or defect. Not just the AML, breast cancer, prostate cancer, any cancer disease, or even, I can tell, they start to use CRISPR even in the space. Like 3 months ago, they start to study the DNA as astronaut. Like they want to study how this gravity affects the DNA. You can like go back and have a look. There is a picture, it's an amazing picture, where the scientists do the CRISPR-Cas9 in the space. So this is the future, inshallah, of the CRISPR-Cas9 technology, and how we can get the full advantage of this technology to treat any disease. So I would like to thank King Khalid University for giving me this chance to come here and give this small talk, the IHOP and the Ministry of Health. So thank you very much for your attention.
Thank you very much for the exciting talk, actually. I'd like to invite both the speakers to the stage for the Q&A session. And if you have any question, please go ahead, introduce yourself and raise your hand. Maybe I'll start off with a question by asking Dr. Shimrani a question. Now, you talked about the introduction and the experience with immune checkpoint inhibitors. With all the guidelines that we have, you talked about international guidelines, and we talked about the international experience and also your experience at your institution. And I don't know if it's really a limited or extensive experience, because we're still learning a lot of toxicity with these agents. But do you feel that how comfortable are we with using these agents, immunotherapy specifically, in your standard patients or even those with comorbidities with other immunotherapy?
Thanks, Dr. Muhammad, for your excellent question. Yeah, I agree with you. We are still learning. These medications are considered relatively new, despite the approval. The approval was in 2013. However, we started using this here in Saudi Arabia, I can say 6-7 years ago. It depends on the indication. In lung cancer now, we can tell you that we have a great experience, especially in first-line setting. Immune checkpoint inhibitors now are considered the standard of care in non-small cell lung cancer. We have actually majority of patients included in our retrospective studies were lung cancer patients. But if we talk about for example, the triple negative first line, we had a very limited number of patients with combined positive score of more than 10 prescribed pembrolizumab. So it depends on the indication. At the same time, with regard to the safety profile, we are still learning. The absolute contraindication, we learned from the clinical trial that, for example, the autoimmune disease patients are not candidate for to use immune checkpoint inhibitors. However, now we receive recommendations from a society of, for example, the rheumatology, supporting use of immune checkpoint inhibitors, even those patients with on immunosuppressive agents. So, to be honest with you, we are still learning, even if after this long period of experience.
Excellent. Thank you very much. Maybe another question for Dr. Al-Qahtani. The technology that you talked about, CRISPR-Cas9, and you've talked about many publications, specifically in the lab or some experiences, but have you come across any technology being used in the clinical trial, whether it's a phase 1 even trial? Did they even make it to a clinical trial? So I guess that's my question.
Yes, this one. So basically, for the clinical trials, the first CRISPR test is the one right now it's been using in sickle cell disease. Okay. They already finished the phase 1 trial last week by chance, and then they are going to start the phase 2 trial in next few weeks, and they expect it to end up these trials by the end of 2025. So there is a lot of work right now in the lab using CRISPR-Cas9 technology to edit the target gene in AML in basically all cancer types. But the first clinical trials is the one that I have explained, which is in sickle disease. They have done in vivo experiments, which is the final stage of experiment usually we do in the lab before going to the trials, in AML, in breast cancer, in prostate cancer. But again, I'm expecting in next few years, inshallah, we will start to see CRISPR-Cas9 in different clinical trials with different diseases, not just cancer, inshallah.
Excellent. Thank you very much. We'll take a question by Dr. Abdul Razak.
Thank you very much. Great presentations. My question about the immune checkpoint inhibitors. Dr. Shamrani, do you think the data or the frequencies and complication, the extension, would it be the same with biosimilars? Is there an implication with differences with regard to the expected prevalence and outcomes?
Thanks, Dr. Abdul Razak, for your question. Actually, we are pharmacists. We believe in biosimilars. We have great experience with monoclonal antibodies in the past couple of years. I guess it will be the same story. We have proven safety and efficacy with biosimilars for targeted therapies, and I'm expecting the same for immune checkpoint inhibitors after a couple of years. So I think it will have similar experience.
In your study, did you include reviewed any of the medications were biosimilars?
I cannot hear you well.
Were any of the medication or the inhibitors in your study were biosimilar, or none of them yet?
None of them, because the first one was ipilimumab, which was approved in 2011, but I don't know about the patency. So we are expecting ipilimumab to be biosimilar soon. This is based on the approval, time frame.
Thank you very much.
Do we
One
still
more
have
question?
time?
Go ahead.
Do we have time? Okay. Thank you very much for great presentations. I have a question to Dr. Taha. In AML, you said there's an active pathway additional to the non-AML patients, which has the JAK and then the STAT5. And you said it's difficult to target the STAT5 because there has been identified two subsets of A and B. Any possibility, or if there is any way that JAK is targeted instead of the STAT5? I'm sorry if you mentioned that in your presentation, maybe I overheard it.
I think this is a very good question. So if we talk about targeting STAT5 itself as a protein, so it's not a kinases, because usually we are able to target kinases. If it's MAP, for example, or ERK or AKT, this is other kinases. So usually the targeted therapy can be easily invented to target this kinases. The STAT5 is a transcriptional factor. It's a huge size, and the different binding size make it very difficult to target STAT5. And because it's unique in terms of the activation in AML patients, we thought initially, can we target the JAK itself, as you suggest? But there is, this is a controversial topic. Some of the paper being published, they said the STAT5, it's directly activated by the FLT3 receptors. There is no JAK protein in between. But other people, they said no. The JAK is the protein responsible for sending the activation between the FLT3 at receptor level and the STAT5. So we decided to go directly and target STAT5 instead of putting ourselves in this debatable situation.
Thank you very much. We'll take one more questions and then we're going to conclude this session. So if we can get a microphone in the middle, please. Thank you.
Assalamu alaikum, dear colleagues on the stage. I have a question for Dr. Majid about, again, with this experience that we've built over the last, in our region, maybe 7-8 years. In the last couple of years, there's lots of debate about the optimum duration of immune checkpoint inhibitors. Some people say 6 months and then complete remission, you stop. Some people say 1 year, some people say 2 years, and some people keep it until disease progression. So what's your intake on that, especially with the studies showing that demonstrated the extended, effect of these even after discontinuation? So what's the practice here in Saudi Arabia? What do you think about that?
Okay, thank you, Dr. Anas. I'm really happy to see you here in Riyadh again. With regard to your question, I think it's an unanswered question, especially in advanced disease. We know now that immune checkpoint inhibitors are approved in adjuvant setting for a short period of time. However, in advanced disease, if the patient develops a complete response, I think, and this is what I heard from most of the experts, that they will be hesitant to stop immune checkpoint inhibitors just to maintain the great outcomes that they get. So we don't have answer for this, but we have learned that if the patients stop the treatment because of the side effects, the response will last for a long period of time. So I think maybe in the future, for group of patients, they may benefit from stopping the treatment, especially if they have kind of indolent disease. But if they have advanced aggressive disease, it will be very difficult to stop it permanently. Maybe extend the dose, to give it every 3 months. Maybe this is one of the idea, to give it less frequently.
Thank you very much. I'd like to thank you all for staying late. It's been a long day, and with this we conclude this session. Thank you very much. I'd like to thank the speaker. We learned a lot from both of you. Thank you again. Thank you.
We would like to thank the moderator and speakers for this knowledgeable, informative topics. Now, let me invite Dr. Yahya Kadumi to the stage for the recognition. start with Dr. Muhammad Nahaf. دكتور ماجد الشمراني. دكتور طه القحطاني. Last but not least, let me introduce you to our last speaker, Dr. Fakhr Al-Ayyubi. Dr. Fakhr Al-Ayyubi is the president of Saudi Heart Association, clinical pharmacist and heart failure specialty.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. And I think, that would be the last presentation for today. I'll try my best not to be so condensed, but at least we have to convey the message. As you know, cardiology was just a session before this one. We end up with oncology, but it's not an easy job to cover and conclude the therapeutic part in this day. Thank you very much, I hope, for inviting me for such a conference. As you can see, it's a hospital practice. And why did I talk about heart failure today? Because rehospitalization is a problem, and we are here to talk about how can we minimize this. Just a little important information about heart failure and some cases to refresh our memory. And in the end, of course, some recommendations and the role of pharmacists. Heart failure by itself, it's a very costly diagnostic disease. It's not easy to diagnose heart failure. Even cardiologists, sometimes they really suffer. The most important thing for me is that the readmission rate, and this is why we are here today. We're trying to decrease the readmission. Why? The more readmission, the more progression and للأسف طبعا death. And this is what we are trying to avoid. Now, the cost of heart failure has been studied globally, and you can see that it's 108 billion per year. We always have to have our Saudi data. We have a Saudi Heart Association that are doing their best to get a national data. And we found that it's really very expensive in Saudi Arabia to treat heart failure patients. More than 380 billions per year it's causing Saudi Arabia. Now again, these data are national data. It's telling us also that we are matching with the global information, which is the number of rehospitalization, more than 60. Still we are in the same rate, and also more than 80,000 deaths per year because of heart failure. 50% of our patients might die within the first 5 years of diagnosis. Now, this is very crucial. We tried different strategies to stop this from happening. That's why you can see lots of molecules have been introduced globally and nationally to come over this problem. Lots of choices are there, but again, what is heart failure to be coming in the coming few slides. Now, part of the risk factors that we could control is something related to disease. We can decrease the comorbidities, but are we able to, for example, work on the biomarkers? Are we able to work about also the adherence? Is Saudi Arabia facing this problem? In Scope 2021, we had the pleasure to introduce data that is from national registries. And to be honest with you, we found that if Dr. Majid said that cancer is number 2, now cardiology is number 1 death. And this is very important and alarming for us. We found, according to the Saudi data, that our major problem comes from non-adherence. So pharmacists are not doing their job, and this is really shame on us. That's why we had to work very hard on working on the adherence. Now, what are we trying to get our patient adherence to? It's a big dilemma. I'm not going to cover it, of course, in 20 minutes. But the most important thing for me is that I want to just simplify the heart failure medications. And the most important one for me today is the neurohormonal model. Now, we're trying to do a balance between the hormones and, of course, to work on the heart muscle, improving its outcome, improving the hemodynamic of the patients, and, of course, the organs that are supplied by blood from heart should be saved, like the kidney and other organs. Now, renin-angiotensin has been proved several years back. We all know that it's a class 1A medication, either A's or ARBs or even RNA. Beta blocker is even again proved to be a class 1A. So again, we have lots of guidelines that really support us and support this practice. The other important thing is the aldosterone, and now it's the practice. Most of us are really using that in the clinics. Which one to use, what's the dose, this depends on the experience, and of course, it's a hand-on clinical experience. Evapridine now, it's back again. We all know that the Saudi FDA had stopped the registry now, so we can use it in the clinics. But again, it's a class 2, it's nothing to talk about for now. We're talking about a major molecule, a very important one that has been introduced 2 years back, the SLG2 inhibitors, and why they are there. They are there to save the lives of our patients who's going to die within the coming 5 years, remember, in the few slides. Now, SLG2 inhibitors had a very unique mechanism of action. It's one of the pharmacological molecules that we really want to emphasize on, and we are happy to have, not just in the heart failure with reduced ejection fraction. You can see now a few coming slides talking about the ones with the normal ejection fraction, where the patients used to come and readmit to the hospital, and we had no clue what to do. Now, SLG2 inhibitors, you could see it works on the electrolytes, it works on the kidney, it even works on the blood perfusion, and of course, the resistance of the after and preload on the left ventricle. All this, by a unique way, have been proved by Imperial Reduce trial, as I told you, that talks about their efficacy in decreasing the cardiovascular death, their efficacy in reducing the readmission and hospitalization in heart failure patients, and of course, the improvement in the kidney function. Now, all this has been proven. We have been practicing this in our clinics. It is part of the guideline-directed medication therapy now, and now we cannot discharge a patient, honestly, without SLG2 inhibitor. This is a crime. The patients could sue you for that. Now, these are one of the pillars that has been proven by the European American guidelines. These molecules have been introduced now, and you can see it's there. It's proven its efficacy, and this is not my concern. Honestly speaking, what I'm concerned about today, and I'm trying to focus on, it's a class 1A now. So please, back to your clinics, back to your hospitals. The practice is changed now. You cannot say that this patient is not diabetic, he cannot be on this medication. Now, the other part is that also ARNI, which is the sacubitril with valsartan, has improved now to be 1B. These molecules are not to be waiting for. You can start them all together with small dose, readmission, walk-in clinics, up-titrate the medications. Now, what I'm trying to talk about now is, again, just a little bit refreshment about the heart failure with reduced ejection fraction. If I'm talking about guideline-directed medication therapy, it has to be led by pharmacists, or if your physician doesn't want to give you the chance to do so, at least discuss the treatment plan with them. You can see now it's so clear that we are treating heart failure patients with reduced ejection fraction, stage C. And this molecule is part of the introductory medications that has to be the patient on. We can accept that you start with low doses in other groups, but SLG2 inhibitors starts 10, continue with 10, start 25, continue 25. Doesn't need an up-titration, so it's an easy molecule to deal with. The other thing is that we know that ARNI is, again, a substitute for HFrEF patients, but again, it has to be titrated sometimes. It has to be followed with the complications and the side effects. Now, the most important thing for me in these slides is that SLG2 inhibitors is introduced with a very clear indications and follow-up plan, even with ejection fraction that is low for heart failure HFrEF, and with kidney function. Look at the statement. It's very clear for me now when I'm talking about diuretics, what to do. If I'm talking about aldosterone, again, you have to follow the potassium for these patients with the kidney function. SLG2 inhibitors, you can introduce it for patients with 30 ejection fraction, GFR. And that means that even with some elimination of the kidney problem, we still can introduce these molecules. Hydrolysine isomac, it's still there. We are using it sometimes in patients who have kidney problems. Now, again, what about the HFpEF? And this is the beauty about it, and that's why actually we are here today. أنا عارفة إنه آخر اليوم وطفشانين وخلاص you want everything to end up وتعبانين بس بعض الأسئلة if you don't mind, few questions, just raise your hand, tell me which is the proper answer. لأنه HFpEF, honestly speaking, we used to just stand, pray for the patient to get out of the hospital alive, but honestly, we had a very limited plan for them, our medications to be used to them. These drugs has been proven to be as good as at least other molecules in taking care of these patients with decreasing the readmission and the hospitalization. As you can see now, زي ما السعودي Heart Association عودتنا تكون عندها Saudi data, Saudi patient supposed to be there now. So Noura is 73 years old. She's a female, and she has, look at this, different comorbidities that leading us to diagnose her with heart failure. You can see now she has ejection fraction, which is 54. That means we're still in the normal level, but she's obese, type 2 diabetic, hypertensive, non-STEMI, COPD, NIHA class 3, and she's a smoker. يعني ما شاء الله كل شيء موجود عندها. تمام? And by the way, it's not something fabricated. We do really have patients like this in the clinic. And honestly speaking, we really have what clue to do with these patients. Now, the other thing which is very important for me, I need to know the medications she's on. You can see she's on aspirin because of the non-STEMI, not because it's a routine in cardiology patient. She's on ACE inhibitors, diuretics, statins, and metformin with semaglutide, which is diabetic medications. So honestly speaking, if you look at it from the outside, it's a good job. The physician who's taking care of her is giving her most of the medications she needs. But still, she was admitted to the hospital. Now look at the reading, and I want you to look at the vital signs. Most of our pharmacists, we don't look exactly about the very crucial information, which is the vital signs. Blood pressure, 132, okay? Now, heart rate is 70. The kidney function is 55 ml per minute. And this is, again, important for me. Biomarkers, you could see now, 350. It's a little bit elevated. And the hemoglobin A1C is 7.8. Now, if I have a patient with that in my clinic, I'm so happy. But it's not right. We still have to improve it better. But because this patient has a lot of comorbidities, we have to look at what is our decision. What should we follow in this patient? And as we can see from the slides, we have new guidelines that support this molecule, which is the SLG2 inhibitor. The Saudi FDA also have approved this medication for the HFpEF. And the most important thing for me is to work on the lifestyle. At the end, follow up the patient. And this is very important as a clinical pharmacist or even pharmacist in the clinics. We need to follow the patient. It's not right to give a medication and just send them back home with no feedback. So I think here that the picture is clear for us. Noura is really suffering. She needs our help. And 2 years back, she has been diagnosed as a HFpEF. So it's confirmed now she has a heart failure with preserved ejection fraction. Because before that, we used to have a problem in the diagnosis itself. Now she has been diagnosed. For me, it's a clear picture now. It's a HFpEF patient. تمام؟ نبدأ بالأسئلة ولا لسه كمان شوية؟ يلا عشان خلاص we can have a break and go back home. What are the possible comorbidities for this patient? What do you think? Is it her gender? Is it her other disease? Is it diabetes? Or is it the age? Which one do you think? 3, 2. Who said 1? No one. 2. Okay, 3. بس دكتور محمد خلاص لازم يكون 3. And 4. Okay, so majority of you will say 2 or 4. It's 2. This patient has all the disease that we talked about, which is the comorbidities. She has the COPD, she has the diabetes, hypertension, obesity, and on the top of that, of course, smoking. So the comorbidities, she has it, and she is excellent in that. And this will lead me to the proper treatment for her, because I need to treat now the disease itself. And you can see now in this patient, her most important thing for her diabetes were not well controlled. You can see the hemoglobin was high. And if you look at the medications she's on, still we have to interfere. Metformin is there, and GLP is there. So I'm sure she still needs help in the two forms, in the diabetes part and in the cardiology part. Right. What are the initial observations for this patient? Okay, في ناس بدأت في الإجابة قبل ما نحط الاختيارات. Who goes with number 1? Okay, انتوا عارفين طبعا HFpEF أكثر البيشنتس هم female. You know that. But it's not where I'm going to change my plan. يعني I would expect diagnosis HFpEF in females, but it's not the only factor that will take me to the proper diagnosis. So gender is out. Diabetes? No. Age? She's 73. No. Hypertension, kidney, and okay. Let us go to the answer. هي دايما التكنولوجي معايا فيها مشكلة. Great. Okay. طيب من ال vital signs we can see that بالنسبة ل what is normal in this patient, 132/78 is not acceptable. It's beyond. She's supposed to be 120, not 132. So her blood pressure is not controlled. The other thing is the kidney, borderline, and the diabetes. She's not doing well in all those 3 elements. So الإجابة الصحيحة فعلا كانت 4, and we have to look at these comorbidities to make sure she's on the proper medications. طيب, what heart failure treatment this patient is supposed to be on? Is it diuretics only? SLG2 inhibitor only? The other way around. Which medication in HFpEF patient it's not mandatory to be on? Which one? Is it 1, 2, 3? 3? Okay. 4 HFpEF patients? 5? 6? Okay, so let's go. I like this kind of answers, honestly. It's nice because it tells me that what level of pharmacist I'm talking to. Now, what I'm looking for this HFpEF patient who's not controlled from different aspects, a medication that's better to be given once daily. The other thing, I want a drug that will improve the patient's survival, يعني عنده data في morbidity and mortality. I want a drug that improves the quality of life even. I don't want the patient to come in a wheelchair. And this is always the case. دائما. Female with HFpEF, more than 60 years, she's on a wheelchair, to tell you that. Another thing, I want also something very important for me to benefit I want to have a benefit that can be seen rapidly. يعني ما أدي medication أو بعد 3 سنوات I'll see the effect. I want something rapid, not just for me, by the way, for the patient's compliance. I want something that is tolerated and safe, يعني حقه side effects تكون controllable. I don't want something that will cause nausea, for example, and vomiting, GI cramps, as much as I can. I want a drug that will work on different aspects: blood pressure, diabetes, and heart. And I want a drug that has no side effects on the kidney. At the same time, it might even improve the kidney function, and this is a great thing to do. I want a drug that is affordable. I don't want something, of course, not even available in the market. And I don't want it to be expensive. and I want it to be accessible. Powder, تحطها في water, drink it every 8 hours. It's not that easy to be applied. A drug that is only available in the institutions, again, it's not really an easy thing to be accessible to. So what I'm looking for is a drug that will be given easily to the patient, have been proven safety and efficacy, at the same time, easy to monitor. Now, we all know about the IMPER-REDUCE study, but also IMPER-PRESERVED study supported that using these medications in patients with HIF-PIF is safe, affordable, and of course, easy to monitor. So the drug that we're supposed to answer, which is not mandatory in her case, is the beta blocker. متفقين? Okay. This group of medications, specifically the empagliflozin, with the Imperial Preserved study, told us that the side effects are limited. What do I mean by that? Number of amputation has been appeared in this study, a few number of amputation, and also the UTI infection, although with our practice in Saudi Arabia, because of the good hygiene, because of the Islamic restrictions and hygienes, we don't see it a lot. So let's say I'm going to start with empagliflozin in this patient, 10 milligram, or dapagliflozin because of the DELIVER study, either or. We are now tackling the HIF-PIF #1 medication for our patients. And the beauty thing about these medications is that there is no need for up titration of medications. Once you start the medication, it will give you the effect. After 3 months, and this is the key elements that I want you to concentrate with me, we need to see the patient after that. We need to see the effect of this drug on the patients and the treatment plan. Look at now the treatment plan. Most of it, it's almost the same. We just introduced for this patient SLG2 inhibitor. And from my own experience in our heart failure program, we found a very good actual results. And lots of patients are coming back, walking to the clinic with less readmission and hospitalization. And this is why, because we did this chart in our clinic, and we do really the treatment plan according to the patients. It's individualized, depends on what we are looking at, what comorbidities we are treating. These are the medications that we use in our clinic. Now, the most important for me is the one tailored to the patient. And this is very important. شفتوا المحاضرة قبل كده كانت DNA tailored to the cancer cell. Now, this treatment plan is tailored to the patient. Another thing that I want you to take home message with you, the adherence. Very important for us. After we give the proper treatment for the patient, the adherence part. If we do not follow their adherence, you're not doing your job. You could see from the data that most of the 40% of the patients do not comply to their treatment plan. So as if you're wasting your time, you're not treating them properly. The most important thing that I think as a pharmacist in the heart failure program, your role is after the diagnosis. We're not going to interfere in the diagnosis, and I know that. But we are there to make sure medications are there. We are on the right dose of those medication. We are avoiding the drug interactions, the complications. Patients, caregiver are educated with their family members because we want a better outcome. We don't want the patient to just jump in the clinic. We want them to take care of themselves by helping them and educating them. Contraindication has to be produced properly in those clinics. Cost-effective now is our era. And why we're doing all this kind of follow-ups? Because after COVID, we all have been hit very hard with the budgets. And we want actually to re-emphasize on other parts in the healthcare system rather than only just treating the same patients again and again. Documentation. Please try your best to work on the documentation. We don't have much data about Saudi patients in our records in the PubMed. So documentation is very important. And I do think that clinical pharmacists are very important in educating the patient about their disease, about their medications, about the follow-up also in the clinics. And the healthcare providers really need us. They need us a lot because without us, they cannot be taking the updates about the comorbidities, the correlation of the drugs with these comorbidities, and decreasing the admission of the patients in the hospitals. Again, we always feel happy when we miss the patient. We want to miss them. We want them to stay at home, take care of themselves, come to us only when they really need us. And there you are. As you can see, we want to work on the lifestyle now. It's the time and the era to improve the quality of life of our patients, make sure they are healthy enough to take care of themselves. Thank you very much.
Thank you for Dr. Layoubi, and we are deeply honored to join us on the stage Dr. Mohammed Shanawi for the recognition.
Before the recognition, does anyone has any question? For Dr. Fakhr. Dr. Majd? Everybody, they are hypoglycemic effect and خلاص they are خلاص they want to sleep. إن شاء الله. شكرا جزيلا.
We have reached the end of our session today. Thank you for listening and have a good evening.